Again, good morning. We have, this is our first hearing of the, of what legislature number are we? Wait, 200 and what?
117.
Oh, well, anyway, 217? First hearing of the Health Committee, Senior Services Committee for the legislature number 217. Welcome, everyone. We have, welcome especially certainly to the public, but to our new members, Mr. Kennedy, Ms. McKnight, Mr. Croach, and Ms. Shapezi. I look forward to your service on this committee and to your input as we move forward. Mr. Fanke, call the roll.
Thank you. Assemblywoman Shapezi is present. Assemblyman Peterson? Here. Assemblywoman Munoz? Here. Assemblywoman DeCroach? Here. Assemblywoman Sumter? Here. Assemblywoman Pinkin? Assemblywoman McKnight? Here. Assemblyman Kennedy? Assemblywoman Jimenez? Assemblyman Green? Assemblyman Benson? Vice Chairman Eustace? Here. Chairman Conaway?
Here.
A quorum is present.
And thank you, too, to our incumbent members, too. I was wondering what that little cross-eyed look was. So nice to see so many of you back and here. I guess our committee's expanded, too. Well, we certainly we're growing into this room. And welcome to our new Vice Chairman, Mr. Eustace. And thanks to Mr. Benson for his very able service in that role just prior to Mr. Eustace taking up the post. So we have an agenda that I think we can get through with some ease, I hope, today. We do have a hearing on lead that will follow the bills today, which obviously speaks to a matter of great import nationally, and which I think is deserving of this committee's cognizance moving forward, so that we might decide, along with our other colleagues, whether or not any changes need to be made in New Jersey with respect to water quality. With that, where's my list? Let's first take up, and this is for discussion only, by the way. I will not be voting this bill out of committee today. I don't see. Is he here? I don't see him. No, he's not. 1042 Land Andrews Act establishes minimum fees for providing copies of patient medical records. Start with Sarah Goldstein, Esquire, MRO Corporation, who is opposed. Now, I noticed there are a few other people who are opposed to this. I would, but who don't want to offer testimony. I would actually like you to reconsider that and take a few moments. Of course, Ms. Goldstein may have the whole thing knocked out, but please, if there's something that, for those in opposition, that Ms. Goldstein happens not to mention, those who have mentioned that they have an interest in opposition, I would want you to come up and enlighten us as to your views. Chance, Mr. Likens, you want to introduce your guest?
Thank you, Chairman, and thank you to the members of the committee. My name is Chance Likens with MBI Gluckshaw. I'm here today on behalf of both Healthport and MRO, and Sarah with me is with MRO. They are what we call release of information companies. And what they do, they contract with hospitals and physician practices to take up the business of distributing health records. And, excuse me, this, there are a lot of steps that go into this. And so while respectfully we're here in opposition today, I think the intent The sponsor's intent on this legislation is a good one and one that we support as far as making sure both people of lesser means and even just regular patients are not paying a bunch of money for their records. And I want to make it clear, we don't think that's happening today. I think as a patient trying to continue your care, getting your record often comes at no cost at all. But certainly we support the provisions in this bill with the 250% poverty level where there's never any cost. The real crux of this issue for us, and what this bill does not do, is separate the third-party requesters. And that is generally a legally authorized representative, generally an attorney who is seeking that record, often for a lawsuit, whether to sue the hospital or the physician. And the Office of Civil Rights has said the third-party requester is not the patient, and we think any legislation done here in New Jersey should make that same stipulation. So with that, I'm going to turn you over to the expert, Sarah Goldstein from MRO, and let her take over.
Good morning, and thank you for having me. And thank you for holding the bill so that we can continue working with the sponsors of the bill and the other affected stakeholders so that we can focus on access to medical records and not just the issue of cost. MRO works with approximately 140 hospitals and clinics in the state of New Jersey, helping them with their release of information processing, meaning processing requests for copies of medical records. We work with these healthcare providers and we lower the operating costs for them by providing highly trained staff who are familiar with HIPAA and other related medical privacy laws so that there are the compliant release of information. We are asking to continue to work with the sponsors on this because the bill as it stands today does not differentiate between the labor and time involved with processing third-party requests for medical records as opposed to patient requests for medical records. Under HIPAA, patients can submit a written request for a written request for copies of their medical records, and under HIPAA, healthcare providers can only charge a reasonable cost-based fee for those records. That reasonable cost-based fee cannot include the cost associated for searching and compiling for those records. It's only related to supplies and to labor directly associated with putting those records together. Under HIPAA, a third-party request for medical records must be accompanied by an authorization, and that authorization must include core elements and required statements under HIPAA. There's much more work involved in processing a third-party request for medical records because there are multiple pieces of information that need to be provided on that authorization to make sure that the patient did indeed understand their rights under HIPAA and understand what they were permitting to be disclosed. One of the materials that we provided today is a workflow which includes approximately 45 steps involved in processing a third party's request for medical records. Those steps are not involved in processing a patient's request for copies of medical records, again, because they do not have to submit this authorization. HIPAA is all about promoting access to copies of medical records for patients and protecting their privacy. Under the bill and the maximum fees, they would apply those maximum fees to all types of requests, and it doesn't take into account the fact that patient requests involve less work than, let's say, a third-party request for medical records. And because there would be more there would be less availability to receive reimbursement for the time and labor spent processing third-party requests for copies of medical records. Healthcare providers would need to allocate additional funds that they're not currently doing in order to subsidize their medical records departments to process these third-party requests. So I thank you again for not taking this bill to a vote today and for allowing us more time to work with the sponsors and with the affected stakeholders. Thank you.
Well, any questions for Ms. Goldstein? I did wonder, so if I understand your argument, and this is the
Yes.
Information you provided as respects the sort of steps that need to be taken with respect to third-party requests. Why wouldn't why wouldn't, to simplify things, these steps be followed in every case? I mean, is there a lot of, protecting sensitive information seems like you'd always have to do that. Retrieving patient-protected health information seems like you'd have to do that in any case. Make sure the proper authorizations are obtained. I'm not sure how much protection we need to give to individuals if they've requested their record. The folks are adults, and sign and authorize people to do things all the time, whether it's be getting a loan for a house or a car or any number of services where there might be sensitive information involved. I have to say I'm surprised that it's a much more complicated issue just because a third party's requested the information.
It is correct, and part of the reason why it's more complicated is because of the requirements under HIPAA for healthcare providers. So there are rules that do not apply to patient requests. So there is a concept called the minimum necessary rule under HIPAA, and the minimum necessary rule means that if a third party is requesting copies of medical records, you can only give them the minimum necessary information, so particular dates of service, particular types of medical records. With patient requests, that rule does not apply. The patient is entitled to, they can just say, please provide me any and all medical records, and then you can provide those records. There's not this concern about minimum necessary, the over-disclosure of records, because again, they are going to the patient. So in addition to the authorization requirement, within the authorization, there are several required statements. One informs the patient of how they would revoke their authorization. Another statement states that the healthcare provider cannot condition treatment for that patient or payment for that patient's care based upon them signing this authorization. And there's also information that's required related to an expiration date for that authorization. So HIPAA adds more requirements when a third party is requesting those records as opposed to when a patient themselves requests copies of those records.
Okay. Yes, Mr. Croce.
I have one question because you mentioned labor and time. And when I think of Oprah and you're talking about certain information, third party, the provider, the person I'd be giving the information to them has to redact. Is that what you're talking like under Oprah? They have to take certain things out, which is going to take them a lot of time and labor to give the document to the third party versus the patient.
So it really depends on what a hospital's policy is. Most of our clients will not redact records because there's a lot of liability associated with that. So let's say a third party were requesting copies of medical records for someone, and let's say they contained protected information such as psychotherapy notes or information related to substance and alcohol treatment. We would request that a specific type of authorization, that the patient explicitly expresses that they are authorizing this type of sensitive information to be disclosed. So that's involved with it. Also, from time to time, there are subpoenas and court orders that come along, and if they're requesting sensitive information, there are additional steps that need to be taken. And in terms of redacting, that can be something that does come up depending on the client and their policies. And another thing that contributes to the labor and time is now that medical records are both stored on paper and electronically, and within the electronic system, each provider may have their own different form of an electronic health record. It's not as easy as just clicking one button. You have to go into each system and making sure that you're getting the appropriate information for the appropriate patient based on what's being requested.
You did mention about the mental health records, and I just happened to be reviewing this the other day for thinking about, the addiction crisis and the stigma around mental health care and the like. And I believe under New Jersey's law, the patient is allowed to request the release of those records without any particular contingencies being placed on it. Now, states vary. Indiana's one, and some of these other states where you have to, make some specific requests or have, specific rights around. But New Jersey's sort of wide open on this. I mean, I don't know when you mentioned this about the mental health records. If I'm authorizing a record to go, the whole record goes because it is one person we're talking about, whether it be their mental or physical health. Now, patients do have the right. Now, you're saying under this that we will inform patients that they have a right, perhaps not to release all of the record. They can, if they choose to, release all the record but mental health records if they wish. Is that what you're saying?
Correct. And
But the state doesn't require you to do that, does it? Is that a requirement of the state?
is it a requirement of the state that the patient explicitly authorizes the release? So,
Of mental health records
of mental
now in
health.
particular, yeah.
Currently in New Jersey, the only thing that a patient would have to explicitly authorize would be the psychotherapy notes or any records written by a psychotherapist. Those require special authorization, but any sort of inpatient mental health treatment records or outpatient mental health treatment records not associated with these types of notes, you don't need to explicitly authorize that. But I am under the understanding that there will be a change in the law come in June or July of 2016 based on some information from a client of ours in South Jersey.
Okay, has this law already been passed?
I have the citation.
I
I'd
don't
be happy.
remember it. I've been sitting around here a long time. I think I would remember that one.
From what I understand, it's going to be more protective of this type of information, so patients' privacy, they need to be more aware of how their records are going to be disclosed and more explicit authorization.
That's
I'd
a
be-
proposal, you say?
I would actually be, I have on my desk in my office the actual citation to what I've been told is coming along in either June or July of this year, and I'd be happy to provide that to Chance.
I very much appreciate you sending that
Absolutely.
forward. You don't have that either? So, okay, interesting. Well, any other, anyone else have questions for Ms. Goldstein? Thank you. Mr. Likens, yes?
Chairman, if I can just, I wanted to add one more thing before we left here, because while we had concerns with this legislation, we do view today as an opportunity. This is an issue that we've proactively been working on for a couple of years, and I didn't say in the beginning, there are 2 regulations that deal with this. The Department of Health has one concerning hospitals, and the Board of Medical Examiners have the other that deals with physician practices. Neither of those have been brought up to date to reflect our current medical practice, and electronic records are not addressed in them. And so what we've seen in other states are lawsuits put together where a plaintiff says, my records should have cost less because they were electronic instead of paper. And so before I left, I wouldn't be doing my job if I didn't point out paper and ink is not what the cost of these records. You have that chart with the 45 steps. Regardless of the format, the work to make sure that the right patient gets the right record, it doesn't vary based on the format. So just before I left, I had to make sure I pointed that out. There is legislation that addresses this issue in a broader way, which we do support. We think this issue does need to be addressed. As we're moving towards electronic health records, we need to make sure we take care of this. And that's it. Thank you very much.
Great, thank you. Mr. Pisa,
Quick question. Just to,
is your mic on?
yeah, to confirm, you guys have absolutely no issues with patients receiving records under this for continuation of care purposes, for indigent people receiving it. It's just the unduly burdensome requests for litigation type of things that we've all seen at times.
That is correct.
Okay.
That is correct. We worked with legal services on another piece of legislation, and the language in this bill we're talking about today, I think, mirrors that as far as the poverty level and those things. Yes, we do not want it to be cost prohibitive for anyone, whether they're poor or people of means, to continue their care. In most circumstances, and I don't want to be wrong and misquote, but in most circumstances, that is not a cost a patient would bear if you were at the hospital getting records to continue your care. So no, we support that provision in this bill completely. It's just that the bill does not separate this third-party requesters, and that is an issue.
On a third-party requester, you would be okay with including situations where somebody had a conservative, was unable to make a decision for themselves, so it was a family member or somebody who was doing it on their behalf, still being included in this for part of the continuum of care. It's just the outside stuff.
Yes, technically, under HIPAA, if let's say a healthcare power of attorney or next of kin or somebody authorized under state law to act on behalf of the patient in making healthcare decisions, that would still be considered a patient request and would be subject to either the reasonable cost-based fee under HIPAA, or if it's for continuation of care, there would be no charge.
And, sorry, one more point. In our written testimony, which you have, I think we said 142 hospitals. We meant contracts with hospitals because various radiation or surgery, different wings may have a different contract with the provider. But in the current market, most hospitals do not pay for this service at all. A company like MRO will contract with them for the right to service those records, and they make their money basically from these third-party requesters. And so right now, there's a very good relationship we have with hospitals and with physician practices, which if caps and certain limits were put on cost, that relationship could change over time. So right now, that is a good relationship that does not cost the hospitals any money.
Very good, thanks. I will note that Lori Clark, New Jersey Association of Osteopathic Physicians, is opposed, no need to testify. Chancellor Likens, we just heard with MBI Gluckshaw, Healthport, we just heard from him. Opposed, no need to testify, or I guess he did testify, actually. Pardon me. Neil Eicher, New Jersey Hospital Association, opposed, no need to testify. And Michelle Azam, Medical Society of New Jersey, opposed, no need to testify. So we have it would appear we have some work to do on this legislation, and we'll advise the sponsor of that, and we will see what we see going forward. Next, we'll take up A2106, Solomon Mukherjee, permits homeless to receive certified copy of birth certificate without a fee. Oh, do we check it?
No, there's just no one.
Oh, no one has signed up to testify for or against this legislation. I would, for the edification of the committee, as I understand it, this bill generates from issues that homeless people often face in accessing services. They don't have, often without any documentation which will allow them to be identified so that they can begin to recover their lives through the help of social service agencies, our social support system, and a birth certificate is often the start of getting that process underway. And this bill is designed to ease that. I understand that there are some concerns that the government has raised with respect to it, and so there will be some modifications to the bill as it makes its way through, but I'd ask for a vote today so that we can get that process going. Mr. Benson and Ms. Sumter, Mr. Fenke, call the roll.
On the motion to report Assembly Bill 2106, Assemblywoman Chapisi.
Provided that some of the security concerns get addressed, I'll vote in favor of it.
Assemblyman Peterson.
Yes.
Assemblywoman Munoz.
Yes.
Assemblywoman DeCroce.
Yes.
Assemblywoman Sumter.
Yes.
Assemblywoman Pinkin.
Yes.
Assemblywoman McKnight.
Yes.
Assemblyman Kennedy.
Yes.
Assemblywoman Jimenez. Assemblyman Green. Assemblyman Benson. Vice Chairman Eustace. Chairman Conway.
Yes.
The bill is reported.
Yes, and thank you, committee. Next, we'll take up A2320. Venery Huddle Conway raises minimum age for purchase and sale of tobacco products and electronic smoking devices from 19 to 21. This bill has been heard in this committee not too long ago and passed with very strong support, and also passed both houses of the legislature. And so I think the issues on this piece of legislation are pretty clear. And so while I appreciate all those who wish to come up, I hope that in respect of time you'll keep your comments and support brief. And we'll move forward and get this bill out and get it on its way and see if we can't do a better job of getting it through to passage. Mr. David Henry, New Jersey Association of County City Health Officials, in favor. Daniel, is that Kinge or Kinney?
King.
A King. Oh, that's a G. Is that right? Just 2 minutes.
Good morning, Mr. Chairman and committee members. My name is Dave Henry. I'm the legislative chair for the New Jersey Association of County and City Health Officials. We've been on record before that we enthusiastically support this legislation, and we hope it passes again. Currently, there's 14 municipalities that have adopted local ordinances to raise the age of smoking to 21, and that has gone very well, but we feel that state legislation would be more consistent across the state, actually. And again, in order to keep my comments brief, we again support this very wholeheartedly and ask that it be passed. Thank you.
Good morning. My name is Danielle King. I'm an undergrad and graduate student at Rutgers University. I'm majoring in public health, health education, and behavioral science. I am also a veteran, and I served in the Marine Corps and deployed to Afghanistan in 2009 through 2010. What encouraged me to speak today was the previous concern brought up in the Senate committee 2 weeks ago, which was the concern that military members should be allowed to smoke considering they were able to sign up for war. We have an extreme duty to protect military members. Just like we raised the drinking age to 21, it is also equally important to raise the smoking age to 21. Currently, in the Marine Corps, 30% of Marines smoke. In the Army, 26% smoke. The Institute of Medicine conducted a study and found that smoking reduces physical performance capacity, lowered visual acuity, and also resulted in poorer night vision than non-smokers. Even the slightest effect on a person in combat can make the difference of life or death. A recent TRICARE study shows that the rate of lung cancer in veterans may be as high as twice the rate of lung cancer in civilians, costing the VA a low estimate of $1 billion a year. Even though smoking in the general population has decreased, it has been steady in the military, which has prompted military officials to try and figure out ways to reduce smoking. This bill of raising the age to 21 could prevent 223,000 premature deaths to Americans born between the age of 2000 and 2019, according to the Institute of Medicine. Among those who could be saved from premature deaths will be those who served. It is our duty to protect veterans and make sure that the life they have after serving isn't in a hospital bed fighting lung cancer. Here today, we have the opportunity to prevent people from smoking at a young age and prevent addiction. Thank you for your time.
Well, thank you, Ms. King, for bringing this testimony before the panel. It is an issue that has been raised, and I think you very eloquently spoke to it. Having served in the military myself, everybody who serves, what do we say? We're the property of the federal government, and we follow orders. Some better than others, and so those who are in the service will, if you're not supposed to drink, then you will not drink, and if you're not supposed to smoke, then you're not going to smoke. So in the past, of course, we didn't know how dangerous smoking was, and smoking was used to deliver nicotine to help with appetite, to help with steady nerves, focus the mind. There are positive benefits actually to nicotine, which ought to be said, I guess. But the detriments, the negative side effects are so great and so overwhelming, and we know that once that hook gets placed into a person at a young age, that far too many will go on to smoke their entire lives and will die prematurely from smoking. So perhaps it's more important than ever to make sure these rules are applied across our services to protect the many men and women who serve there. We want them around for a good time to come, and preventing and getting them a little older to prevent them from smoking will go a long way to ensuring that that's so. Thank you. Next, we're going to bring up. Any questions? I'm sorry, Mr. Green.
First of all, I want to congratulate you on your testimony. and also I do support what we're trying to accomplish. But I would like to, you gave us percentages of basically what's going on with the different branches of government. I guess my concern is that, have there been any pushback in terms of individuals saying, I'm old enough to go to war, but now you're telling me that I'm too young to be able to smoke? What's the feeling among the people in the service when it comes down to they feeling their rights are violated? I live in a world where I see so much, no matter when you're helping a person, you're doing the right thing for a person, you're going to get that negative impact. And I would just like to want to be in a position so that when I mention what percentage do smoke, don't smoke, and how do they feel in general about this particular issue? Is it being accepted because we're trying to do the best thing we can to help them with their health, or is it being challenged?
There definitely is a challenge. A lot of smokers feel very strongly about being able to smoke, but at the same time, there's proof that a lot of military members are trying to quit. I think it's around 52% of those who do smoke have tried to stop quitting. So I think if we can stop them from smoking at 21, before 21, that it would be in their best interest. So in my opinion, it doesn't really matter that they feel like, oh, I should smoke, oh, I should smoke. It's more about what is good for their health. And I feel like we have the opportunity to help a person before they become addicted.
Saying or how you feel about the issue in general. So I think once we pass the law, is it a way that once we start to educate them, that we can win them over, or they feel like their rights are being violated? Because you have some that's just against wars. This go back 50 years now. They're against anything that we feel is the right thing to do. But so many people nowadays feel their rights are being violated. As a person who's going to support this, I like to be able to respond in a positive way other than we're telling you what's good for your body.
Something I would just mention that, we're trying to do something in the interest of public health and to promote long-term quality of health and prevent bad outcomes down the road. I think what happens is, in collaboration with a number of different parties and organizations, I think it'll become more normal as time goes on, that we've raised or potentially raised the age of tobacco purchasing. But, it's not only enforcement, but it's health education, it's health promotion, so that people become normalized to this. I don't want to belabor too much time, but I remember going to bowling alleys where they used to be smoke-filled, and then the Smoke-Free Air Act came around. And now, the bowling alleys were concerned that they would be affected economically. But now I see parties on Saturdays, Sundays. It's a whole big family affair. So I think what happens is, it's not like we're trying to be big government. We're just trying to provide an alternative to have people live healthier lives for a longer period of time.
Thank you. We're going to bring up, appreciate your testimony, Karen Blumenfeld, New Jersey Gas. Maureen Weber, Abba Point of Care. Is that Abba? Oh, that's two T's. Abbott Point of Care. Amy Barkley, Campaign for Tobacco-Free Kids. Okay. It says 2320 on here. Well, come up for that bill. It's got the right, I guess, wrong, Got the wrong bill number on there then. Ms. Blumenfeld,
Yes,
2 minutes.
it's good? Yes, it's good. I always get misled when it's red, which means no, my light is opposed to green. Good morning, everyone. My name is Karen Blumenfeld. I'm the Executive Director of the nonprofit Global Advisors on Smoke-Free Policy. And I want to thank you, Chairman, as well as the committee members that are here today that were supportive of the bill last term. And again, thank you again for being supportive of it in this legislative session. Our expertise is pretty wide when it comes to Tobacco 21. One of the things that we do is we provide educational resources to the communities around the state of New Jersey that want to do 21 on their own. And just to share with you, 16 towns in the state have done Tobacco 21, and many more are in the process of doing it. So there's definitely that grassroots local momentum to have this happen. And as I go to town council meetings and Board of Health meetings on this, I just want to share with you that I've really witnessed firsthand an enthusiasm and a commitment by local policymakers to try and help their town's young people not to start smoking and to help people quit. And because of this, many of them have passed their own local ordinances, hoping that it would be the impetus for the state to move forward on a statewide level. Now, some towns have decided to wait, and so we're very thankful again that you all are looking at this initiative early on in the legislative session, and that it's already passed on the Senate Health Committee side as well. Just a couple of things I want to share. Policies that reduce teen and young adults' access to tobacco have been shown to lower smoking initiation rates, and it's obvious that less tobacco use will translate into lowered smoking-related health care costs. It's obvious that in New Jersey, we spend $3 billion a year in smoking-related health care costs. So an initiative like this, which is, has virtually no cost whatsoever, except for most likely putting up signs, is something that can definitely help. Last year, a federal study showed that 250,000 lives would be saved if tobacco were raised for sale to age 21 and older, and that's why the New Jersey chapter of the American College of Physicians, as well as their national organization and the American Medical Association, also support this. A note on e-cigarettes. It's not a footnote. I can't say any more because this last year's study showed that a tripled increase in young people using electronic smoking devices. We're glad to see that it's continuing to be in this particular bill because, as I noted, the increased use in youth using these products, plus there's no marketing or advertising restrictions on e-cigarettes. New Jersey was the first state to ban the use of electronic smoking devices back in 2010. So we're proud of that. And we're also proud of New Jersey for last year, or last session, passing the law that requires child-resistant packaging. Thank you to Assemblywoman Pinkham for that, and others that were involved. There's also peer-reviewed studies that conclude electronic smoking devices not only hazardous to the people that use them, but hazardous to innocent bystanders that breathe in the air. So the bottom line is that Tobacco 21 initiatives, they do reduce smoking, they do improve health outcomes, and they will save taxpayer dollars. And I just have one quick question about the bill, if I may. Because there are communities that are passing this policy, I just have a question to confirm that the bill does not preempt local towns from doing these types of policies if it were to pass. Just like the Smoke-Free Air Act has a no preemption clause in it that allows towns to do more, we wanted to ask the question to confirm whether or not that, unless it hasn't been thought about yet, but we would prefer that there be clarity when it comes to no preemption, just because of the history of New Jersey with always starting on the local level and then moving to the state level, and thanking those that have been the forerunners in this particular area. Thank you.
Well, as I understand, the bill will preempt state law and when there's an overlap, will preempt local ordinances, and as I understand it, that's the case here. But the goal has been accomplished in any case, and hopefully people can still, if they want credit, can take a healthy chunk of responsibility for getting the state to do the right thing. So
Thank
let's
you.
focus on the positive.
Thank
That
you.
way? Ms. Barclay?
Thank you, Chairman Conaway. I'm Amy Barkley. I'm with the Campaign for Tobacco-Free. How's that? Okay. I'm Amy Barkley. I'm with the Campaign for Tobacco-Free Kids, and we're based in Washington, D.C. We're a national organization that monitors tobacco prevention policy change and supports that change in all the states throughout the country. And I just want to make one point, because Karen made the case very well for the bill itself, but I wanted to let you know that really the eyes of the public health community nationally are on New Jersey. Those of you who've served the state for a while know that historically New Jersey's been a leader in tobacco prevention efforts, and unfortunately now has the dubious distinction of being the only state that's not using tobacco-related revenues to fund tobacco prevention and cessation. And consequently, progress on youth smoking is stalling somewhat. So we'd like to see New Jersey return to its leadership position and become the second state after Hawaii to pass this legislation to raise the age of sale for tobacco to 21. And thanks to those of you who have supported this legislation before.
Great, thank you. We're going to move on. Next, I'll just note that Mr. Likens, representing the March of Dimes, is in favor, no need to testify. Michelle is on Medical Society of New Jersey, in favor, no need to testify. Ms. Orlando, American Heart Association, in favor, no need to testify. Deborah Brown, American Lung Association, in favor, no need to testify. Ethan Hasbrook, American Cancer Society, whose testimony has been submitted, in favor, no need to testify. Lynn Nowak, New Jersey Society for Respiratory Care, in favor, no need to testify. Diane Litterer, New Jersey Prevention Network, in favor, no need to testify. Libby Vinson, New Jersey YMCA State Alliance, in favor, no need to testify. Sal Risalvato, New Jersey Gasoline and Convenience Store Association, opposed. Mr.
Chairman, no need to testify.
No need to testify. Mary Ellen Papard, New Jersey Food Council, opposed, no need to testify. Rich Levesque, New Jersey Vapor Retailers Coalition, opposed, no need to testify. Actually, I'd like to hear from Rich, but we have maybe some other time. John Hollop, New Jersey Retail Merchants Association, opposed, no need to testify. Anyone else on this legislation that I perhaps missed? Amendments on this, and with that, I'll entertain a motion on this bill. Mr. Eustace, Ms. Sumter, Mr. Fanke, call the roll.
On the motion to report Assembly Bill 2320, Assemblywoman Chapisi.
Come on. You can.
And this is going to actually surprise some people, my vote, but I'm very consistent on if you're old enough to essentially do everything. I don't like picking and choosing and saying, I'm somebody who would lower the drinking age. So on this, I'm a no.
Assemblyman Peterson.
Look, I don't advocate for smoking. Never smoked myself. Never have any intention to smoke. But like Holly, I think we have to have some consistency when somebody's an adult and can make adult decisions. Either they're an adult at 18 or 19 or 20 or 21. Used to be a time in this country that 21 was when you became an adult. We changed that because people could sign up and go fight in a war, make the ultimate sacrifice at 18. So we changed everything to 18, and now we're slowly coming back to 21 on everything. And I think maybe that's where it should be, 21 for everything. And if smoking is so bad, maybe we should just outlaw tobacco, and we should stop talking in this legislature about legalizing marijuana, which is no better. So we should be consistent. We send a message to our children when we say, don't smoke, but we're going to legalize marijuana. We send them this conflicting message. And kids are smart, and I've been at a DARE ceremony where a 10-year-old asked that question. It's legal in Colorado. Why is it bad? Why can't you smoke? They asked that question. We need to be consistent. So I hope that this body, if you really think tobacco is that bad,
And it
we
is.
should be against legalizing marijuana as well. because it's the
Well,
same
that's
thing.
another bill, and I've provided some latitude,
And
but
so
I think
on that, I'm going to be consistent and vote no.
okay. Look forward to your bill to raise the age of adulthood to 21. That might not actually be such a bad idea. Ms. Munoz.
I'm going to be consistent and vote yes. And marijuana in these other states is consumed like gummy bears, so we have to be careful about legalizing marijuana, because I agree with Eric on that. And,
Is that up for vote today?
No, but I'm being consistent. I want to get, I'm voting yes.
There you go, vote yes.
I'm voting yes.
Mr. Croach, let's go on, that's your job.
Assemblywoman DeCroach.
There you go.
Assemblywoman Sumter.
Chairman, I'm going to hold my peace and just vote yes.
That's a good woman.
Assemblywoman Pinkin. Assemblywoman McKnight. Assemblyman Kennedy. Assemblywoman Jimenez. Assemblyman Green.
I'm voting yes, but I would like to make a statement in terms of my position on this particular issue. One, I'm going to support it because I feel that we should educate the young people, and we should be able to look out for people's health who don't look out their own health. But again, we need to be consistent in terms of people's rights. So my reasoning for wanting to put it on record is that if we're going to basically say what's good and what's bad, then we have to take a stand when we talk about people's rights in general. So that's my reason for voting the way I'm voting.
Assemblyman Benson. Yes. Vice Chairman Eustace.
I'm going to vote yes, but I agree with some of my colleagues about the age of people being able to serve in the military and making rules about what they can do, about what their age of adulthood is. I do think that we should spend more money on smoking cessation programs, and that should come out of the tobacco revenues, and I think that would be a better direction to go. I think any way to reduce habitual problems is a great way to go. I'm just not a fan of assigning ages to it, and to Assemblyman Peterson, I hope you feel that way about booze. It costs us a lot of money, federally and state-wise, to take care of problems created by alcohol addiction. Thank you.
You don't need to respond to that now. We have lots been said about this question of age, and I'm just going to say I would invite members of this committee and members of the public to bring to our attention the various pros and cons of raising the age of majority to 21. I think you do make a good point about consistency there, although, you have, governments are frequently inconsistent, and you can, and they are rather easily explained by the exigencies of war, needing to have, well-enabled able-bodied people serving in the military that might, and particularly given the control environment, the command and control structure within the military, that might it's a very different thing from freely entering into a contract by a house to do other things. I think there are distinctions there which are important where the military is concerned, which really, in my mind, don't make the military unique and really not critical to decisions on this issue. So I would say yes, happily, and thank this committee for their time, and let's hope we can get this all past the line this time.
And the bill is reported.
Next, we'll take up A 2332 Benson, S 976 Gordon Beck. Requires Public Health Counsel to promulgate rules and regulations for the use of quality control programs and bio-analytical and clinical laboratories. Mr. Benson, comments on this?
This passed last term. Again, the goal here of this bill is to update department regulations to allow a whole host of testing that's done on a regular basis and allowed to be done with fewer regulations because of the certainty of no errors, or if there was an error, there is no harm to the patient. These are already approved at the federal level. This is just getting the state to approve, to promulgate new regulations to expand the very small list they currently have to now match what's at the federal level. This reduced costs, obviously, for patients. It also provides greater access for these testing in greater locations.
Great. We have Ms. Maureen Weber in favor. Ms. Weber, representing Abbott Point of Care.
Thank you, Chairman, and thank you to the committee for allowing me to be here today and to speak in favor of this bill. I feel very strongly that this will help healthcare in the state, and it will also have some focus on reduced cost for healthcare in the state. I do work for Abbott Point of Care. Abbott Point of Care is a vendor of laboratory testing devices. The type of device that we provide is one that's brought to the patient, it's brought to the point of care, and it offers both waived laboratory tests, which are these simple tests that the FDA has said are so easy to perform that the likelihood of getting an erroneous result is negligible, and also moderate complexity tests. And I bring that up just so that you're aware, in the state, we can't even sell our instrument because the state only recognizes 8 wave tests. These tests were from an old version of federal regulation, and the state has not kept in pace with that federal regulation. The state has a Clinical Laboratory Improvement Act that is from 1975, and they have not updated that. It's based on an old federal act from 1967. So we've had conversations with the Department of Health and asked, have they increased their ability to revise the requirements for the state? Have they made any efforts on that? And for years we've heard that they're making efforts on this. Well, in looking at why it might be a challenge, they're basing an old act on an old federal act. And in order for them to be able to change the requirements, we need to change the fact that now CLIA 94, Clinical Laboratory Improvement Amendments, have come out and been amended since that time, and that's what they need to be focusing on, that version. So that made it challenging for the department. Also, they have a Bio-Analytical Laboratory and Laboratory Directors Act. That's from 1953. So again, the focus of this bill is to move forward with federal legislation, which the majority of other states utilize. The majority of other accrediting organizations also have to use that for laboratories as well as their basis or foundation for quality of testing, for wave testing, and for other requirements. This bill does focus also on quality control testing, and the reason for that is the way that the requirements are written in the state. Again, they're based on this old federal requirement. It doesn't take into account advents that have been made in technology that look at electronic or procedural controls that can be utilized, and in utilizing those, it reduces cost for quality control testing, and it also reduces time for testing of those laboratory devices. It also looks at the wave testing. Again, I had said before, there are only 8 wave tests recognized in the state of New Jersey, and this is because of an old piece of legislation federally. There are hundreds, over 100 tests that are available for laboratories to be able to use, but not in the state of New Jersey. And I'll tell you where this really hits my heart. I think about long-term care facilities, about extended care facilities, about facilities with senior citizens, and they have a change in their healthcare condition. And the physician who's caring for them doesn't have the piece of data to know exactly what's going on with that patient. What they oftentimes will want is a piece of laboratory data to be able to make a decision. And what they do is they'll have a courier come, collect a sample, send the sample off to a reference laboratory because they can't afford to have a laboratory in their own facility that would perform these type of tests. And they have to wait. It might be 4 hours, it might be 8 hours. And in the meantime, the patient's condition can either deteriorate, may maintain the same. And what they'll do is they'll treat the patient on site the best they can. They end up moving that patient to an emergency department where they'll decide what to do with that patient, probably repeat those same laboratory tests if the results haven't been back yet, and then readmit the patient back to that facility. That $450 or $500 ambulance ride is unnecessary. The patient probably is confused with being moved from one locale to another, and certainly they didn't get the care that they could have had in the facility where they're at because they couldn't get wave testing done in that facility. Things as simple as electrolyte testing that would give them a clue as to whether or not the patient is significantly dehydrated, tests that could be done to help them to determine if there's a strep outbreak in that type of facility. These are waived tests in other states. They're not waived in the state of New Jersey. And then lastly, there's a piece of legislation that also concerns personnel and the oversight of those personnel. We're asking here that the personnel regulations be in concert with the federal regulations and not back from 1953 when this act was put in place, the Bio-Analytical Laboratory and Laboratory Directors Act. That's primarily what I wanted to say, but if there were questions, I would love to be able to have a dialogue.
Well, I would ask, because people have called in the office in advance of this bill, and I certainly support it. I would be curious to know, however, there's a phrase there, and I generally agree with harmonization between state and federal law, but often states will have more stringent requirements to deal with particular health and safety concerns of the state. And so, and in our federal system, states very typically will have, regulations that go beyond the federal regulation, because the federal regulation could only pass a sort of a watered-down version of whatever it is they're trying to do. And states, being laboratories for democracy and other ideas, can go beyond that when they feel it's in the best interest of their people. This bill, will it generally raise or lower standards that are designed to protect health and safety here in New Jersey?
Sure. So I would say, in my opinion, particularly with the quality control piece, that would actually raise the standards. Right now, the way that it's written in the requirements in the state, laboratories would be forced to test liquid quality control on a routine basis. On the federal side, they actually have something that allows the laboratorian to look at the testing process from start to finish, look at the risks that are in that process, and write an individualized quality control plan based on those risks. And it depends on the test complexity. There's 3 levels, the lowest level being this wave testing, moderate and high complexity. But these moderate complexity tests, they would be able to write a more comprehensive quality control plan under that requirement. That's on the federal side. In terms of the personnel requirements, it depends on which type of testing you're talking about, but some of the requirements are really too stringent in the state. We don't have enough laboratorians that meet the requirements that are written in the state requirements to be able to perform wave testing under that individual for the bio-analytical laboratory director. So making it so stringent that you can't perform these type of tests in the locations where they need to be performed is not in the best interest of healthcare for patients in the state.
I see. The only thing I would just comment, and again, I'm going to support the bill, that there have been concerns raised in the past. I've sat in those meetings where, patient compliance, getting patients the tests they need, I'm all for that, and by and large believe that that is the case. But there have been concerns raised about, perhaps over-testing when you have in-house testing. And it's a very difficult issue for us, because I know if I have that patient, I've got them in the office, I can get important information I need right there. They don't have to take off work. They don't have to come back in. If they have transportation issues, we can take care of it, take care of their needs and our diagnostic needs in one shot in a visit. And that increases compliance and, in my opinion, improves outcomes. But I know that there's concern about the overordering of tests that may occur. Is that a concern that we ought to be worried about in the context of this legislation?
I'm not seeing that as the issue here, but I appreciate what you're saying. There could be concern of overuse of testing, and that's not our focus here, to drive people to do more laboratory testing. That's not the focus at all. The focus here is to be able to get the right kind of testing. The example that you used is a perfect one. In a physician office laboratory, typically they'd want to be able to perform these wave tests on their patients so that a senior citizen doesn't have to get public transportation, go to another facility, get the laboratory testing done, come back to the physician again, or have a phone call from the physician and make a determination, are they going to change medications for this patient, or is there additional testing that needs to be done? And I don't mean laboratory testing, I mean other types of testing. It's an unfortunate situation that we're in right now, that the patients that are in the state here have this kind of bouncing ball that they have to do. They have to go to a different facility to get blood work done.
And that's terrible, I will tell you that. I think that's not good. It's
is.
bad for patient care. And it's driven by insurance rules and everything else. It's something that we may wish to take up at some point, but I tell you, with the focus being on outcomes, as it ought to be, one of the drivers of outcomes, one of the detriments to getting to a good outcome is, can you get the testing you need at the time you have the patient in the clinic, and you sort of have them captured, if you will, so that you can get the diagnostic work that you need done. And patients, anybody who's involved with healthcare knows very well, you've got to, particularly if you work in a hospital, you've got to leave and go someplace else. And the minute that patient leaves the clinic, the likelihood of getting that needed test done and getting it done on time before the next visit goes way down. And it's a shame, but people, have to work, and they have transportation difficulties and other challenges that they face. And, it's really something we need to try to get our hands around. We need to do a better job in that area, particularly if we're going to focus on improving outcomes, as we should do. Thank you. Anyone else for this, from Ms. Weber? Well, we're going to move on then. Thank you very much. Mr. Endyke, Healthcare Association of New Jersey, in favor, no need to testify. Samantha De Almeida, New Jersey Hospital Association, in favor, no need to testify. I think that's everyone. Anyone else on this piece of legislation before I ask for a motion on Ms. Pinkin?
Well, I was contacted by somebody who was a pathologist in one of the hospitals who did have some concerns. They raised it late on Friday. I really don't have the details, and they would like to express their interest to you at some point.
Well, and to the sponsor, most principally, Mr. Benson will be very glad to listen to anyone who has a concern about the legislation, because he'll want to make sure it is as good a piece of legislation as we can make it. So please refer them on to the sponsor, and I'm sure their concerns will be heard. Did I hear a motion from Mr. Eustace and a second from Mr. Benson? Mr. Benke, call the roll.
All right, and there are technical amendments to Assembly Bill 2332
With technical amendments.
to update the dates on which various requirements in the bill take effect and to make it identical to Senate Bill 976.
Wonderful.
So on the motion to report Assembly Bill 2332 with amendments and Senate Bill 976, Assemblywoman Shapisi. Assemblyman Peterson.
Yes.
Assemblywoman Munoz.
Yes.
Assemblywoman DeCroce.
Yes.
Assemblywoman Sumter. Assemblywoman Pinkin. Assemblywoman McKnight. Assemblyman Kennedy. Assemblywoman Jimenez. Assemblyman Green. Assemblyman Benson. Vice Chairman Eustace.
Yes.
Chairman Conway.
Yes.
Assembly Bill 2332 is reported with amendments. Senate Bill 976 is reported.
Great, thanks. Congratulations, Mr. Benson. Next, we'll take up 3101, Conway. Permits registered surgical practices to convert or to combine with ambulatory care facilities, provides for phased-in gross receipts assessment, authorizes nonprofit hospitals to acquire joint ownership interest in practices. Speaking on this bill, we'll have Mr. Mark Manigan, New Jersey ASC Association. Mr. Manigan.
Thank you, Mr. Chairman and members of the committee, for this opportunity to talk to you about this proposed legislation. It stems from a long history of the state trying to figure out how to kind of regulate these unlicensed, so-called unlicensed surgery centers in the state. It goes back to some legislation that came out of this committee in 2000, I think it was 11, that was subsequently vetoed by Governor Christie, which would have required unlicensed surgery centers to become licensed, but it would have exempted them from current ambulatory care facility rules and regulations, and also the ambulatory care facility assessment. We've tried to develop a middle-of-the-road strategy with the front office through the Department of Health about whether there was some middle ground that they could tolerate in terms of ambulatory care standards. It was very difficult to do so. The issue quickly became that any kind of standard that we were honing in on would have forced many one-rooms to close or undertake unaffordable investments and renovations. So as a result, the proposed bill would seek, through using a carrot as opposed to a stick, to encourage investment in one-room surgical centers. It would permit them to convert to licensed facilities. It would permit them to combine and become licensed, meeting current standards. It would permit them to combine with existing licensed facilities to meet current standards with no net increase, consistent with the letter and the spirit of the Cody Law moratorium against the development of new surgery centers in this state. It would permit those transactions, and it would also, to encourage this kind of investment, phase in the applicability of the ambulatory care assessment over a 5-year period. The last thing the bill would do is it would permit hospitals to invest directly in the 150 or so one-room surgery centers that exist in the state, with the hope that that investment could help increase standards, et cetera. So that's a very high-level review of the bill. We thank the sponsor for his support, and I'm happy to entertain any questions or comments that anyone has.
Ms. McKnight?
Hi, how are you? Is there a reason why for-profit hospitals are not included?
That's an issue we're happy to work with the sponsors on the bill with, and you know, I don't think that's the hill for my client to die on.
Okay, thank you.
You could live, you know.
I don't know.
Get that flag raised up there, you know. You're going to charge the hill and get the flag raised. That's what, you know. Anyone else on? Anyone else for Mr. Manigan on this bill? I would note that Dr. Mitch Riker, president of the New Jersey Orthopedic Society, is in favor of this bill, but does not feel he needs to testify. Anyone else on this legislation? If not, I'll entertain a motion on the bill. Ms. Jimenez? Ms. Pinkin. Mr. Finke, call the roll.
On the motion to report Assembly Bill 3101, Assemblywoman Chapisi. Yes. Assemblyman Peterson.
Yes.
Assemblywoman Munoz. Yes. Assemblywoman DeCroce. Yes. Assemblywoman Sumter. Yes. Assemblywoman Pinkin. Assemblywoman McKnight.
Yes, with the exception of adding for-profit hospitals.
Assemblyman Kennedy. Yes. Assemblywoman Jimenez. Yes. Assemblyman Green. Yes. Assemblyman Benson. Yes. Vice Chairman Eustace. Yes. Chairman Conaway.
Yes.
The bill is reported.
Thank you. Next, we'll take up AJR 50, Wimberley Conway Venere Huddle designates May of each year as Youth Smoking Prevention and Awareness Month. We have a number of people who need to be recognized in this bill. Recognized only, I suspect. I hope. Ethan Hasbrook, American Cancer Society, in favor, no need to testify. Lynn Nowak, New Jersey Society of Respiratory Care, in favor, no need to testify. Karen Blumenfeld, New Jersey GASP, in favor, no need to testify. David Henry, New Jersey Association of County and City Health Officers, in favor, no need to testify. Libby Vinson, New Jersey YMCA State Alliance, in favor, no need to testify. Sharon Seiler, New Jersey School Boards Association, in favor, no need to testify. And Anna Hansies, NJEA, in favor, no need to testify. With that, I'll entertain a motion on the resolution. Ms. Sumter, Mr. Eustace, Mr. Finke, call the roll.
On the motion to report Assembly Joint Resolution 50, Assemblyman Peterson. Yes. Assemblywoman Munoz. Yes. Assemblywoman DeCroce. Yes. Assemblywoman Sumter. Yes. Assemblywoman Pinkin.
Yes, I just want to make a note that I was a sponsor on the last version and will sign up again to be a sponsor on this version as well. Thank you.
Assemblywoman McKnight. Assemblyman Kennedy.
That's one bill I'm thinking of doing.
Assemblywoman Jimenez. Assemblyman Green. Assemblyman Benson. Vice Chairman Eustace. Chairman Conaway.
Yes.
The resolution is reported.
It's a real pain, and it's a detriment to good patient outcome. Next, I guess we'll adjourn this hearing. Mr. Green.
And an issue that we really talked a lot about, and maybe Assemblywoman Munoz want to add to it. This tier type of control over what insurance companies do, is that regulated by the governor's office, or do we have any input? could we have a hearing on that particular issue? Because I know majority of the mayors in Union County feel that this is really hurting their ability to offer the kind of services they need to offer. And also, it almost puts them in a situation where they're losing control. So I guess my question to you, the decision in which way we go with this particular issue, is that something that can come through our body of government, or is that something that the governor's office controls? Senator Munoz, if you want to add on to what I'm talking about, I would appreciate it.
You do?
I know that you were at the press conference last week, talking about the Omnia, obviously, Horizon Healthcare, and the issue regarding access to care. I know you're in Burlington County, we're in Union County, and Trinitas Hospital, which is a major provider, is not one of the Tier 1 hospitals. But I think Assemblyman Green and I and the people in our area, as well as your area, are very concerned with this classifying things as Tier 1 and the potential to drive these really excellent hospitals out of business, because they're forcing all the patients into the paying patients into the Tier 1s. So that's what Assemblyman Green is addressing. And whether or not we're going to take it up here. You wanted me to finish what the question was. Whether we're going to take it up here or at some other venue.
Well, I said well a couple times there, because the Omnia, and I should say not Omnia, but rather tiered networks, are not on the agenda today. We have taken it up, as you know, in this committee, and there have been a number of bills that have been offered, which, and a number of them are now in other committees. It's not to say that this committee will not take up further the issue of tiered networks, but it is an issue that will be taken up by the legislature. I have assurance that that will take place. Now, as respects the issue at hand, if the question is might this committee Well, I'm not opposed to a hearing on the issue. We'll certainly take this issue. There certainly may be reasons to take this issue up again. As I say, their legislation is moving in the legislature in both the Assembly and the Senate, and there may very well be a time, particularly appropriate time, for this committee to take up the issue again of tiered networks again. I have mentioned on the record and continue to say that, like many here, have concerns about the impact of tiered networks. Tiered networks are not new. You mentioned whether or not the governor's office is involved in this. Insurance plans, as you know, submit their plans, their insurance plans, to the departments for review. We have a rather deregulated marketplace with respect to those types of plans and their use in our marketplace. And I imagine there are some who will want to take up that question going forward, and it's their right to do so. And legislation on that will be reviewed as all pieces of legislation are reviewed, to see if they get the support and if they can get a hearing, if they can move forward. So. If your question is, are we paying attention to what's going on with respect to tiered networks, the answer is yes. And there may very well be a time when this committee will need to have further discussions, more discussions than we've already had on the issue. And when that time comes, we'll all know it together. So thank you for that question, unusual as it is at this time, but I appreciate it. And nonetheless, I would like to adjourn this hearing and move on to the question of our public hearing on water quality in the state of New Jersey. As you know, so we're adjourned on that. Let me just, I guess that makes it official. As anybody who's followed the news and the reporting, I cannot help but be concerned and dismayed at the situation in Flint, Michigan, that has resulted in a public health crisis with really long-lasting implication for those affected persons who live in Flint. And it's naturally raised a concern around the country and certainly here in New Jersey that for our own water supply and our own water quality, I'm sure a number of you have over your career taken an interest in this issue. As many of you know, we passed out of our committee a bill to regulate, to put an MCL on 123 TCP, which has shown up in high concentrations in the water supply of one of the towns I represent in Morristown. As I understand it, has been addressed by DEP and will continue to be addressed. And as I expressed in that legislation, I had concern that it's not just the town of Morristown which may be facing difficulties with this. Any communities which were once farming communities with housing on it, any communities which once involved in industrial operations may see this particular contaminant in their water. And I, for one, I think the state should have a state-wide testing program on this because it is a known carcinogen and has been known to be so for some time. We also have the issues around lead, which are certainly in the news, and we want to make sure that we're doing everything we can to protect people from exposure to lead. And so we're going to hear from people involved in that game and other water quality issues during this hearing. First, we're going to bring up New Jersey Citizen Action Ann Vardman to offer testimony on this issue, along with the Housing and Community Development Network of New Jersey, Stacy Berger, and along with Isles Incorporated, Elise Pivnik. However you choose. Now, I don't know everyone, so, well, you've got your light on, you look like you're ready to go, so please introduce yourself, and we'll be happy to hear from you.
Thank you, Chairman. My name's Ann Vardaman. I'm the Program Director at New Jersey Citizen Action, and I would really like to take the opportunity to thank you for holding this hearing. What has happened in Flint has raised the consciousness about this issue across the country, and what we've what's come to light and what we're here to talk about today is that this is a crisis in New Jersey. Last year, more than 3,100 children were poisoned by lead in New Jersey. If this were a virus, an illness that was going around and causing brain damage in 3,100 children, you would think that we would be investing a lot of resources in preventing that from happening, especially something that is entirely preventable, like lead poisoning. And that's not what's been happening in New Jersey. Instead, funding that's supposed to be going to the Lead Hazard Control Assistance Fund has been diverted into the general fund. Now, I would just like to take a moment to read a quote about lead poisoning from...
I just want to be clear about one thing before going forward. Now we know that lead has an access to it can not only come through water, and we are focusing on water, and I do... I want to be sensitive to the fact that there are other sources of lead, but I would really like to focus on water, and lead itself generally we could take up as well. But I just want to, as you make your points about lead and lead poisoning, if you could try to clarify whether we're dealing with a waterborne situation or something that is in the environment, housing, lead paint, and the like, I'd appreciate that as you go forward. Just a comment.
I mean, I'd just like to say, the primary source of lead poisoning in New Jersey is from paint in old homes. However, if you live in a home that was built before 1986, you also have lead pipes for your plumbing, which means that there is the possibility of lead in your drinking water. And part of the issue is that if you are being exposed to lead in your home from paint, from dust, from dirt, the lead that's coming in your water also then continues to build up. You have the situation where often if you're in a house that has lead paint in an older home, you also have lead pipes. Therefore, there is going to be some lead in your water. But the primary source of lead poisoning in New Jersey is from paint. 1986 for for pipes for plumbing. However, for paint, it's 1972. So even in a home that would be designated lead-free, for example, because there's no longer lead paint, you could still have lead plumbing. And like what happened in Flint, the issue is that while lead pipes are generally safe, if you have a corrosive agent in your water that breaks off more of the pipes, then you're going to have higher lead levels in the water going into a home. So yeah. You want to go ahead?
If someone wants to, as you mentioned, the corrosive elements that are added into the water to deal, I think, with questions of cleaning the water, but also we know has an impact on the sled. Someone can talk, anyone who coming up who can speak about these sort of anti-corrosive elements that are placed into the water and what their potential impacts might be. I'd appreciate some information on that as well. You are?
I'm Stacy Berger. I'm the president and CEO at the Housing and Community Development Network of New Jersey. We're the statewide association of 150 community development organizations, many of whom have been on the front lines working to rehabilitate homes and communities that have suffered from lead. I have no expertise in water contamination or corrosive elements, so I don't even want to purport to talk about that, but I did want to share a couple of issues that have come to our attention. First, I wanted to tell you a little bit about what we've heard since we kicked off the Lead-Free Kids New Jersey campaign, which you may have read about over the last few weeks, because of what's happened in Flint, which is a horrible, terrible, criminal situation. We have really taken a refocused look at what's going on here in New Jersey and feel very strongly, as do 109, I believe, other organizations that have signed a letter to the governor and to legislative leaders asking that the $10 million that's been dedicated, 50 cents per gallon of paint purchased in New Jersey, that money is required under the law to go to the Lead Control Hazard Fund. That is where it should be going. We know that the impact of lead in paint is completely preventable. It costs about $5,000 to $10,000 maximum to rehabilitate a home that's had lead poisoning. It costs about $32,000 a year to deal with a child who has special needs and disabilities as a result of lead poisoning. So we can spend the money now, or we can spend the money later, but we're going to have to spend that money, so we may as well do it in a way that saves lives and improves the quality of life for people who live in our state. I just want to share with you one quick story that we heard that it broke my heart that I couldn't help this woman before she got to this situation. We were contacted by a young woman named Tara McGill, South Jersey mom. She and her family moved into a beautiful Victorian home in Collingswood, built in 1890, and she was informed that it was completely gut renovated and totally clean. She didn't know anything about lead, didn't have any reason to ask about lead, never was disclosed to her by her landlord that there were any issues there. Wasn't until after they moved in that they found paint peeling in various areas of their home, and they paid for an out-of-pocket inspection. They found a dust level in their foyer of 131. HUD regulations allow under 40. And the central AC and ceiling vent in the kitchen had about 56 blowing out into their entire home, basically spewing lead dust everywhere. By the time her daughter was a year old, she had developed tooth decay, she had developed streptomyces. I'm not a doctor, many of you are, so most of you know that's better known as cross-eyes. Am I pronouncing it incorrectly? Thanks. She stopped thriving. She grew only an inch or an inch and a half in the time they lived in the house. She stopped sleeping. She started screaming. At about 2.5 years old, which is about she is now, she fits into about 18-month-old clothing. Her daughter and her parents, and these parents are going to live with the impact of that for the rest of their lives. Completely and totally preventable. And she called us and said, "Can you help my daughter? Can you help us?" And I said, "I will do whatever I can to put you in touch with whatever resources we can find, but this should never have happened. It shouldn't happen to Tara McGill, and it shouldn't happen to any other child like hers. We can absolutely fix this if we decide to put the resources that are needed to make that happen." And that's really what it comes down to, whether we decide that we can and will do what is necessary to make sure that we protect the future generation of New Jersey's kids. So we really appreciate you having this hearing today. We know that in some cities, the pipe situation is a problem in some schools. I know that WNYC reported earlier this month that the city of Camden is using bottled water for its school children at the cost of about $75,000 a year because there's lead or suspected lead contamination in their water pipes. So that's something to think about when you hear from experts that have more expertise on the water side, is whether those schools have the adequate resources they need to either address the pipe problem or figure out a way
I guess not if you're buying bottled water.
Pardon?
I guess not if you're buying bottled water.
Right. I mean, it's not a great use of resources to buy bottled water because we're not actually fixing the problem,
Never
but
mind
it
the
is way
plastic.
better than treating kids for lead poisoning or allowing them to be poisoned in the first place. So we really appreciate your interest and enthusiasm about solving this problem. We need everybody to do this. This is not a partisan issue. This is about children, and it's something that is completely preventable, and we have dedicated tax revenue to do this. So please make sure that that goes in the budget.
Ms. Pivnik?
My name is Elise Pivnik, and I'm the Director of Environmental Health for ISLES. We're a Trenton-based community development and environmental organization founded 35 years ago to foster more self-reliant families and healthy, sustainable communities. I've been working in the community development field for over 30 years. I serve on the board of the National Center for Healthy Housing, and I have a graduate degree in city planning. So I've been working on these issues both at the state level, at the national level, and also looking at things at the local level, because it's all those levels that need to come together for a solution here. It's not just one actor here. Because of Flint, Michigan, most of the world now knows lead in water can poison children. The deplorable water scandal is an important story, but it's just as tragic and alarming that thousands of children in New Jersey continue to be exposed to lead year after year from lead paint in their homes. Lead paint is by far the most common source of exposure. The facts are not meant to be competition with Flint, but to highlight the neglected lead poisoning story of thousands of children in New Jersey. Since 2000, about 225,000 young children in New Jersey have levels above the CDC reference level of 5 micrograms per deciliter, 3,000 new cases in just 2015. Children with this amount of lead are 30% more likely to fail third grade reading and math tests. They are 7 more times more likely to drop out of school and 6 times more likely to become involved in the juvenile justice system. I've distributed some packets. There's a table here which tells us in 2014, New Jersey reported equal to or higher percentage of children tested with elevated blood levels above 5 in 11 cities in New Jersey in comparison to Flint. So one of the things when the Flint tragedy broke is they were talking about the numbers in Flint, and because I've been looking at New Jersey data for years, I went back to look at the New Jersey data. And for the year 2015 in Flint, there were 112 children that had levels above 5. In Trenton, New Jersey, in 2014, which is when our latest data, it's 214 children, I believe. You look at Newark, you can see the numbers there. So this is an ongoing problem in New Jersey and all of our older cities. This is not unique to New Jersey, but we have got the tools that to put together to solve this problem. I also added a table because I also got some data that looked at the number of children starting kindergarten with elevated blood lead levels. And this is an important distinction. What you're looking at here is annual data. This tells you that in a single year, this many children were tested and this many children had levels above 5. But if you add up the single highest test for children who are starting kindergarten, you've got a number that's 2 to 2.5 times greater for children starting school. So if you want to look at, there's a table here. You can look at, it says in Camden, the latest year I have data for is 2012 to 2013. 13% of children were starting school with elevated blood lead levels. In Irvington, it was nearly 20%, New Brunswick, 10%, et cetera. And I can go over this data with folks at another time. So you may hear that people say that the reduction in lead poisoning over the last 20 years is a great public health success. And if you're looking at national data, indeed it is. But the national data conveniently hides a harsh fact. Lead poisoning disproportionately affects poor minority children, primarily in our nation's oldest cities. Minority children's rates of lead poisoning are 2 to 4 times the national average. I think if you are a parent in Trenton or Newark, you do not think we have a public health success. So while we've removed lead from gasoline and paint in the 70s, what we do know that there's still many homes in our older cities that are obviously carrying hazardous levels of lead. Out of 1,500 homes that Isles has tested in Trenton over the years, more than 60% had enough lead to present enough lead present to affect a child's IQ. So the cost of this hazard continues to be immense. And one of the points I really want to emphasize here is that what is strangely misunderstood is that the costs of lead poisoning are primarily borne outside the health sector, in social and economic costs, in special education, disproportionate incarceration of young minority men, family stress, and lifelong disability payments for children who grow up into be unemployable adults. So there's a study published by the New Jersey Public Advocate back in 2009 that said basically a child who's been lead poisoned will cost government about $31,000 per year, probably could be up to the rest of their lives when you just count in a lot of other things. So what does it cost to make a home lead safe? Our experience at Isles, where we do make homes lead safe in combination with doing energy improvements, it's between $5,000 and $12,000 a unit, and the cost not to remediate, again, is at $31,000 per child per year. So the most effective methods for reducing lead poisoning is what we call primary prevention. That is making the home lead safe. The way we work now is we test our children, and they're like canaries in the coal mine. Once they become poisoned, everybody comes to attention, and they may go to the house to look what the problems are. It doesn't make any sense. And we could be doing a proactive program of inspections. There are cities and states in the country that are doing a good job of this. State of Rhode Island, now you have to have a lead safe certificate in order to rent out a home if you're a landlord in Rhode Island. And there's just been a study published by Professor Janet Curry at Princeton University, and she showed that by making lead-safe home repairs in Rhode Island, by requiring that they have a landlord have a lead-safe certificate, there was a reduction in racial disparities in education by 54%. It's huge. It's huge. So we're here to say that New Jersey can do better. While New Jersey has programs of education and training about lead poisoning, particularly strong in the New Jersey counties affected by Superstorm Sandy, it's not enough. And there are a lot of specific actions I would love to review with you. I've included our strategic plan for healthy homes that we worked on for the state of New Jersey. There's a draft in your packets. And obviously, we think it's very important to restore the $10 million to the Lead Hazard Control Fund, because prevention, again, is the key to reducing lead poisoning. You don't want to go in after a child has been poisoned. It's really too late. And this fund gives an opportunity for low-income homeowners and landlords who rent to low-income tenants to make their homes lead safe. And it's a missing piece of our arsenal to fight lead poisoning. So there's other things. There's I
think you probably landed a good place to end.
Good.
And we will take up the information in this packet. I think I'm speaking for all of us when I say that that we have a great interest in this issue. You do speak to this question of as a charged term, environmental racism, but just the disparate impact of how that comes to people who live in poor housing stock, who live with poor resources to deal with these kinds of challenges, and have follow-on challenges that go out of control because of things like lead poisoning, which interfere with your ability to get the education you need to pull yourself up out of poverty in the first place. So it's really a scourge that we have to take on, in my view. And I would ask On the, in terms of the numbers that are shown here, those people who are presenting with greater than 5 milligrams per deciliter of lead in their blood, how were those children discovered? Was it testing in their pediatrician's office? Was it a public health program that went through a neighborhood and either drew blood or did, I don't know if a finger stick works for this or not. I mean, if somebody's come up with a finger stick for this or
Well,
not.
there's a capillary test and a venous test. But
the capillary test.
in most most instances, it would be the pediatrician. There may be some, cities that have done public health programs, public health events where you bring in children to have them tested. But typically, it is done in the pediatrician's office, and all tests must be reported to the state, and that's where you get an annual lead surveillance report.
So this is folks who have a pediatrician, then take their child to the pediatrician, and the pediatrician then tests them, and that's how these numbers are appearing on these charts. So that if you don't,
Right, you could go to a public health clinic as well. I mean, it's not. There's, you know.
But who access the healthcare system? So you have to access the healthcare system for the most part, in order to show up in these statistics in the
Correct.
and so, which is why the numbers may be lower than anybody thinks that they are.
And, again, remember, this is just 1 year of children coming through. For children starting kindergarten, they might have been tested at age 1, age 2, age 3, age 4, or 5. So, these numbers in most instances reflect
Let's
about.
go more. I know that other people have questions. So you just raised something. Now, if you are discovered at age 1, and I think probably there might be somebody come up to speak to this, now we test you again at age 3. What I'm trying to get at, is there a tracking of that child who presents at age 1 so that we hopefully know that their number's going to, well, just a minute, we're going to hear about that.
So, I'll just speak to that. So the Department of Health can tell you whether a child was tested at 1 or 3. The problem is nobody does anything with this information. It's as if there's a firewall between the Department of Health and educators who you think would care a lot about this information. And I'm calling your attention to a document that was published last May by the CDC. It's called it's Education Interventions for Children Affected by Lead, and it calls for early monitoring, early developmental assessments, enriched programs, et cetera. And in fact, it's the document that's being followed to make recommendations for children in Flint who are affected by lead. And I suggest that the children of New Jersey deserve nothing less, and that we should be looking at how we can bring education, health, housing together to do a more comprehensive plan for helping children. We can be much more efficient in what we're doing.
Ms. Sabiz, did you have a question?
Yes. I'm somebody who absolutely believes in keeping our water healthy. One of the first bills I ever did was about drinking water, not being able to flush stuff into drinking water. So, I'm somebody who's very balanced about this stuff. But I do have questions because I think oftentimes in politics, in public health things, we can create hysteria that sometimes is not there. And so I just want to go through some of the things that were discussed and try to understand it, because I have vastly different data and I'm just trying to get my arms around what's correct and what's not. Numbers of 3,100, 3,000 new cases were put out. With respect to the 5 millimeter threshold that's being used, what states in the country use the 5 millimeter threshold?
Okay, it's a good question, because I think what you're getting at is
a milligram, sorry.
Is probably that the state of New Jersey considers 10 the actionable level. And so most states who receive CDC funding have adopted the CDC reference level of 5 and above micrograms per deciliter as the actionable level. And the CDC says that that is where children are at risk at that level, and they also state in the same report that there is no safe level of lead. In other words, we see a lot of impacts now at levels as low as 3 and 4, and I can again direct you to the Education Interventions report by the CDC where they summarize the research, and I'm happy to distribute that to you. So one of the things that the state of New Jersey has not adopted the CDC reference level. And it's a political choice. It's not a choice that's particularly based on science. So,
Can you tell me what states have adopted that level?
you know what? I actually have a table, and I don't have it here. I'm happy to share it with you, because I did the research on it. But just about all of them have adopted the level of 5 and above. And I think it's 22 states or slightly higher have been funded by CDC for lead. Not all states are funded by the CDC for lead surveillance.
Okay, because it's my understanding that there are only 17 states in total that even require universal screening for lead, and New Jersey is one of those 17.
And that's excellent. That's excellent. We get a lot of, that's where we should be. We have a very deep problem here, and that's excellent.
So out of the screening that has taken place, and the numbers that I have for 2015, that there were 205,607 children who were tested for lead, compared with just 10,298 because of these additional screenings. But out of the 2015 data from, I think, the Department of Health, only 885 children had the elevated levels pursuant to the current thresholds in New Jersey.
So I think, again, that's using the levels of 10. New Jersey is saying that this Department of Health says our actionable levels are at 10. The CDC is saying that 5 is an actionable level, and I chose to compare levels of 5 to levels of 5, whether it was Flint, Michigan, New Jersey, or whatever. So I believe that that's what their numbers are referring to, and those numbers are much lower if you only look at levels of 10 and above.
And with the Flint reference, one thing I just want to make sure that we're accurate on, the Flint numbers that were provided excludes the 8,000 new cases that came about as a result of the infiltration of the water supply from 2015.
So here's a tricky thing. So what we know is that it's about 9,000 children of 6 and under live in Flint. That's U.S. Census data. And I think what people describe is that all of those children have been exposed to lead. What we know is since when the water changed in April of 2014, okay, what we know is between then and through January of this year that they tested approximately 2/3 of the children who of age 6 and under, and there's been 186 children who have tested high. So it's a very different number to say the number of children who have been exposed versus the number of children who actually have elevated blood levels by doing the venous test or whatever test was done for those children.
By the way, just for clarification, that's at the 5 milligrams per deciliter or the 10?
5. I'm talking about 5. And I have the Michigan data with me. I'm happy to share it. And what I did try to do is I tried to compare only a single year to a single year. It was not accurate to take the 18 months of exposure and compare it to 1 year of exposure here. And I'm happy to go over all the details. Your questions are really good, and I'm very happy. I'm pleased to be able to clarify this.
That because,
it makes you dizzy. It makes you dizzy.
You want to make sure you're comparing oranges to oranges and that we're looking at this the right way. And I don't think anybody sitting up here would say lead poisoning in children is good under any circumstance. It's more a function of, what is the appropriate approach, making sure that we're doing it in a well thought out way rather than just a reactionary way because we saw something really bad happen in Michigan. And so I'm just trying to educate myself.
Let's get to the meeting then. We have some questions over here, and we'll come back if we need to. Mr. Eustace?
Thank you, ladies, for your testimony. Ms. Pivkin, you said you've been involved in this for 30 years.
I've been working as a city planner for 30 years. I've been involved in healthy homes and lead poisoning prevention for the last 10.
Okay, so prior to that, I'm sure many people in the room remember the national TV commercials about Pika and instructing parents on not to have children eat lead chips and things like that. And I was just curious, number one, what was your take on that education process? And number two, is this part of prenatal education or pre-parental education? Because we won't be able to solve the houses immediately, but I remember a national program where they talked to parents about not letting your kids eat paint chips, not letting your kids do 3 things I think were on the list. And I'm just curious, if you thought that was successful, should we resurrect that? Because taking care of the homes isn't going to happen overnight, but if we could address something with a public service announcement, I think that
Absolutely.
would
I think
accelerate
those are great points. And I think what happened here, there's 2 things. We took lead out of gasoline and we took lead out of new paint. And that resulted in a huge decline in lead poisoning nationally. Again, you have the stubborn continuing pockets of lead poisoning in our old inner cities. So what's happened is that the public says, well, aren't we done with this problem, right? And our educators say, aren't we done with this problem? I had occasion to talk to the now former superintendent of Trenton Schools, and he said, I don't know why we stopped talking about lead. I have no idea who's lead poisoned in my schools. And the special ed staff said the same thing, because we don't even require that lead screenings be shared with educators. So when you enter school, you don't have to submit a lead screening to the school. And we don't even share the data that's collected with in most instances for poor children, it's collected with Medicaid money, right? And it sits in a database. And the Department of Health is doing its job. They're not at fault. There's this firewall here, and educators don't even know to ask for the information. And we can just be doing a much better job coordinating what we know with what we need to do. And if we don't even define the problem well, we're not going to solve it. So people think the problem's disappeared because they never even look at the lead surveillance reports, which is a whole nother story because they're very hard to read.
It's a good place to end right there on that for that. Mr. Peterson, and then we'll come back to Ms. Pinkin, and then quickly. What do you want to talk? You wanted to mention something about water?
Well, we're talking about lead in water, right? Wasn't that the...
That was yes.
Well, I know a little bit about this because New Jersey back in 2001 passed a statute that required testing of water. And out where I live, you have wells. We predominantly have wells. So in 2002, the law went into effect, and it did 2 things. It required every time a house was sold, a transaction occurred, there had to be a water test done at the source and at where it comes out of your faucet. And then those test results come back, and it's not just lead, it's everything under the sun, because arsenic is an issue, radon is an issue in water, there's all these other issues. And then it comes back and tells you what your concentration is of different things in the water. And lead is one of the things that is tested for. If there is lead in the water, and the city of Camden should look into this, if there's lead in the water, there are systems that will take the lead out of the water and make it safe to drink. They're not very expensive, but it's just one more thing you have to do in your water, like a water softener or what have you. Now, as far as public water supplies go, you probably have all gotten them in the mail if you have a public water supply. They have to do a test every year, and then they have to notify you of the results of those tests. So our water in New Jersey is constantly tested. And one of the good things about the private well water testing results was it allowed the DEP to track to see where there's problems with water in New Jersey outside, because a lot of that water ends up in your public systems, comes from my area and ends up downriver where you guys take it out. So there's this testing going on. So our water system is pretty good. As far as the lead pipes, I'll tell you, I looked at thousands and thousands of home inspection reports. I've never really seen any lead pipes. Cast iron, copper, PVC is more common. But what the issue is with lead as far as piping goes was there was solder that had lead in it. It's a low concentration of lead in it. And there's some lead in some copper piping, but very little. What happens is the solder is really where the issue is. If the soldering wasn't done well and you have corrosive water, the pH is off or what have you, it can seep into the water.
Well, Mr. Peter, what's the point of this?
Well,
what are you trying to get to?
I thought this whole thing was we were worried about what happened to Flint, Michigan. Is it happening here?
Yes.
And the issue is that New Jersey's way ahead where that couldn't have actually have happened here because of all the things that we've done to take care of it. here in New Jersey to prevent it. I mean,
There-
we know
there-
about
I
lead
would,
paint.
I would
It's
agree
been-
with you that there are a number of things here, and I would agree with the statement that we don't want to cause alarm. But it also is true that we do have problems, and we have to take cognizance of them. There are issues about testing. The question is how frequent they are, and then what's done with respect to notification of the public and what kinds of actions need to be followed up to make sure that there are remediation. The testing program that you're talking about, the actionable level, not every home is tested. There's a statistical analysis of that. Now, if your home happens to have lead in it, in fact, I was helping my dad with one of his houses in Bordentown. We were digging up. He had a lead water pipe going into the house. So there are issues around lead that we know that are spotty. That involve infrastructure, that involve things in the environment, that involve any number of things, and you've got to get at all the points. And the main thing is to find out what's happening at the tap, what's happening in the home, what's happening to the children who are being affected. So I appreciate this history about it, but we're going to be running out of time. So is there, if your point is that we have a pretty good regulatory system in New Jersey, I would agree with you. Is it perfect? Nothing is. Are there things that this legislature ought to do with respect to water? There's no, and particularly the private wells that you mentioned, because I had to deal with that situation myself in the testing, so I don't know about that firsthand. Then we ought to find out about it, and we ought to do what we can to improve it. Ms. Sumter, you have a question.
Thank you, Mr. Chairman, and thank you, ladies. I was more concerned with the type of registry from the state, especially when I know that pediatricians and healthcare systems report birth defects, and they are adamant about the facilities reporting this data as well as private practitioners. Can you tell me again what happens with that information?
So my understanding is information gets, for any lead screening levels, will get forwarded to the Department of Health. There's a lead surveillance unit, and they publish an annual report. And it has many tables in there that says, tells you about children who are, I think it's, age 3 and below, and then there's the children who are 6 and below. It reports by city. If the town is 50,000 people or more, it reports by county. You have, it's very hard to follow, for starters, and one of the things that is happening in other places that we could easily do here is start geocoding this information so you could start seeing where the concentrations are. Obviously, without personal addresses, you do it with color of concentration where things are. But the information never gets to the educators. It never gets to the teachers. It never gets to the special ed folks. And, I have a story from several years ago about I was talking to a principal in a Trenton school, and they were trying to figure out what was going on with the child. And finally, the father stepped forth and said, do you think that, my child had a high lead level. You think that might have something to do with it? And it was like a huge piece of the puzzle for them. So we have this information, and it's not being used to the benefit of the child. The reason we screen...
Points made on that. Ms. Pinkham?
Mr. Chairman, may I just add one piece very short, briefly to that? The other piece of tracking that is not done is for 1 and 2 family unit homes. The state is supposed to be, under the 2008 law, inspecting and tracking and publicizing 1 and 2 family units for lead in the home, and that is not happening right now.
Well, we have to find out about that.
That's why I wanted to raise.
We have other people that want to come up, and I'm worried that you're providing a lot of information, but I'd like to get the questions out quickly and the answers out quickly so we can move through it if we could. Speeches. But do you have a question?
I was just going to say that generally they test the
Is it a
children.
question?
No, it's a comment. At 18 months and 6 years, and even for the pediatricians, it was difficult to get the state to give that information back. And we would say, why are we not doing geomapping? Why aren't we looking at it overall? And we could never get the data in talking to the surveillance groups.
Well, good. Well, that's something we need to work on then,
Absolutely.
it sounds like. Thank you, ladies. We're going to bring up the next panel. We have Daniel J. Van Abs, PhD professor, research professor at Rutgers University on the Clean Water Council. We have Dr. Puthead Madam, Dr. Rad. You put Rad in parentheses, and I tried anyway. So you're going to have to do it for me. MD, PhD, and FAAP. Gentlemen. Dr. Van Abs, I guess we'll start with you guys there
Mr. Chairman,
first.
committee, thank you for having the invitation to be here today. The Flint, Michigan issue that we have seen has major health implications for its residents. It's important that New Jersey takes the right lessons from this and not the wrong lessons from this. First thing I'll say is that the Flint, Michigan issue is the result of a systemic failure in the decision-making and regulatory process. That's been acknowledged at this point. Water professionals know how to deal with this issue of lead in water. They know how to deal with this issue of copper in water. There is absolutely no excuse whatsoever for what happened in Flint. So the question is whether New Jersey should be worried about this issue. And when you're dealing with these risk assessments, you're dealing with three different issues. One is structural, second is treatment, and the third is management. With regard to structural, there's absolutely no doubt that we have places in New Jersey, mostly the older urban and older suburban areas of the state, where we have lead lines that are running from the curb to the buildings. And we have, in some cases, lead lines within the buildings. In other cases, we have copper lines with lead solder. The big issue is probably those lead service lines between the curb and the house, and then you have additional issues as well. So we have this. And if we have corrosive water, and by the way, corrosiveness is a whole chemical issue.
One of the principal issues in Flint, as I understand.
Yes, yes, that plus stupidity.
Yes.
And so the corrosivity, pH issues, buffering issues, and so on. So the second issue is whether the lead in our plumbing is being allowed to cause a problem. And in general, the answer is no. But I am aware of some systems that are up close to the action levels, and they are trying to figure out how to deal with this issue. There are a number of New Jersey systems that are already adding anti-corrosion compounds, phosphates, polyphosphates, orthophosphates, to their water supply systems to knock down the lead levels. They're adjusting their pH to knock down the lead levels. The question is, the problem is that there's no such thing as perfect. The use of these treatment technologies is to minimize the lead level. The only way one eliminates the lead in the water is by eliminating the lead in the systems. And that's a very expensive process. So the third...
I'm sorry, you said
Yes.
lead in the systems. Now, are we talking about lead in the pipes and solder and copper pipe systems? Or are we talking about lead that's in the water because of the way the water percolated through the ground and then is sucked up and put into water treatment? Both of those things, or one of them, when you mentioned lead in the water?
The lead levels that come from water supply treatment systems are negligible. The issue is not what comes from the treatment plants. The problem is what gets picked up in the water as it's being sent from the treatment system out through water mains. Even in the old urban areas, you may not have lead lines, but you often will have lead joints between sections of steel because it was a very malleable way of dealing with this. So you may have lead joints there, and then you have the lead service lines from the curb into the building and so on. So the amount of lead that we get from the treatment plants is negligible.
So the answer to my question then is the piping systems that we're using either in the system or that part of the piping that is beyond the curb that allows lead to turn as the water comes into the house?
That's correct, sir.
That's
Yes. So the third question is whether New Jersey could have something happen like in Flint. And one would certainly hope that no water utility would be so inappropriate in their management as to do something like that, and that our regulatory system would not allow for it. But one thing we should recognize is that municipal, utility, and regulatory staff can all feel pressured to minimize alarm, to adopt a bunker mentality, to minimize costs. And so this is something that you have to guard against. We've been doing a good job, but it doesn't mean that it's permanent. So it's something that you can never let your guard down. I should also mention that the treatment that is required for these systems is essentially permanent, because you can't ethically be treating water to reduce lead and then decide at some point, well,
it's only a few people that are going to get poisoned, and therefore we're no longer going to treat. So this is going to be going on for essentially forever from our perspective. The other aspect of this, though, and this is where I'm going to add to
It's
the
nothing
issue.
so gloomy. It wouldn't go on forever. If the pipes change and we're not putting lead in the water through the piping, then it wouldn't go on forever.
Well,
and we get
the
the lead out of
question
the
is,
houses, then it wouldn't go on
if we have tens of thousands of homes who have these kinds of issues, how long is it going to take us to modify tens of thousands of homes? So from a political
Better know what they are.
perspective, I will say it's going to be generational, maybe not forever, but it's generational. This is going to take a very long time. So the other issue, of course, is that the lead issue is only one piece of the entire puzzle, because these very same areas have very old infrastructure, and it's aging very fast. And so in addition to the lead issue, you have the fact that we're getting water main breaks all over the place. This is going to be, when you deal with water supply and wastewater, tens of billions of dollars of costs over the next couple of decades to deal with these infrastructure issues, plus the private costs in New Jersey, plus the private costs of dealing with lead issues within the properties, within the property boundary. All right, so I was asked when I was invited to throw out some ideas that the legislature might consider, and I'd like to pose a set of ideas. One is very much in line with what Mr. Peterson raised about the Private Well Testing Act. The notion that statutory changes to require the elimination of lead service lines in rental properties within some period of time and for homes upon sale or transfer might be a really interesting idea and way of dealing with this. DC has been replacing thousands of lead service lines. Lansing, Michigan is almost done with their process. It is feasible to do this. Tied to that, how can water supply utilities and other entities provide interim financing to property owners for the cost of replacing the lead service lines and the lines within their homes? Some people just can't afford this stuff as a single chunk of money coming out of their budget. Third, and this ties to the issue of assets, the urban water assets as a total, our statutes are not really clear in terms of giving DEP the authority to require asset management of water utilities, wastewater utilities in New Jersey. Our regulations are focused on water quality at the point of delivery to a customer, at the water quality of effluent discharge, but they say very little about the integrity of the water utility systems in between those 2 points. So that's an issue that could be looked at. Fourth, all of this is going to drive water rates and sewer rates up. And they're going to drive them up in places that have a lot of very poor households. For energy, we have a household assistance program. For water and sewer, we do not. And so how could the state look into that kind of issue? And finally, and this might be coming a little bit from left field, but you've all heard of cities that have been talking about selling their water utilities, their MUAs, and getting money in to use for general tax abatement or whatever it happens to be. I would argue that the users of those utilities paid for those utilities. And so if there is money coming in, it should go back to the benefit of those customers. And one way it could do so is by applying it to the costs of lead service line removals, of infrastructure improvements, and so on. 5 ideas, just food for thought. Thank you.
Very much appreciate that. Doc?
Hi.
Dr. Rod?
Thank you, Mr. Chairman. I'm Dr. Radhakrishnan. I'm known as Dr. Rad in Trenton. I've been here for 25 years. It's a funny position that I'm in because I've been a patient advocate, a child advocate, and now I'm bringing you information on as to what the DOH is doing because I've been involved with this lead program in New Jersey for 25 years. When I first moved to Jersey in 1990, we had a lead advisory committee that the state had set up along with the DOH, and I participated in the first guidelines that were issued for providers and for communities as to how to deal with lead poisoning in the state of New Jersey. So I just wanted to address a couple of the issues that that did come up from the previous presenters, one of the issues was, what are we doing with this data? Are we providing it to schools? Are we providing it to other people? New Jersey, we do have a form that's called a universal form that's given to all children who either go to preschool, daycare, or to regular school. And on that form, we do initiate the resulting of lead levels onto that, because there is no other way to provide this to the schools. There is a spot on that form that says what was the last lead level done, when was the last PPD done, and along with that, that's for the height and weight and stuff. But so it is there. And as far as what the DOH is doing, there was a question about the registry and, what do we do with the data? Unfortunately, that registry at this point does not include lead levels, and we are advocating for it both on the part of the American Academy of Pediatrics and from providers that this include lead levels so that it's available statewide. And that hasn't happened yet, so hopefully it will one of these days. As far as tracking the data, the state has done an amazing job over the last 25 years, coming from where we had no data at all to a point where they required that every single lab that does a test on a child, it doesn't matter where the test was done, it could have been done in Timbuktu, but if that child lives in the state of New Jersey, that result needs to come to the state of New Jersey, and the DOH has that, which is amazing. And that data is available to anybody who wants it. You can call up the Department of Health, and they'll be happy to give you that information. So,
But do you guys post it on a website? Is it available for researchers to get to?
Yes, it's available for researchers to get to by requesting. It's not available on our website. There is data that's available on the website, but it's not individually to communities, towns, school districts, stuff like that. But that's something you can get by calling the Department of Health and asking them for that specific drill down data. And there have been a number of studies that have been done. Newark did a great study a few years ago about this. They were able to pull the data from the Department of Health and compare it to what they were seeing at the university centers. So this data is available.
State data is available that you drill down. Do you mean as identifiable data or as de-identified data?
No, it's de-identified. It's not per person.
All right.
Yeah. So that's very important to remember. We've come to a point where when I started in practice 25 years ago, we were thinking of 40 being a level that was significant and actionable, only because that's the only thing even today, we can't treat a lead level of 10, of 12, of 15. We can only treat a child who has had a lead level that's over than 40. And there was some question about, lead levels being done by capillary testing versus lead level testing. The whole thing is the capillary testing is a screening tool. It's very important. It's freely available. Every pediatrician in the state pretty much knows that we can do a capillary test right in the office, send it off on a MedTox form, and get the results back. The only point is...
I'm sorry. I keep interrupting. I apologize, but I have to do that. Now, did I hear you say, because I was on with DEP, maybe they didn't give me, that you said you can't treat, what can't you treat until it gets to 40 milligrams? What is this?
We talk about an actionable level of 5
Yes.
now that the CDC wants, but what action? What they mean by action is education, nutritional information, screening, and continuing to watch this kid and do the test every 6 months. And we have a schedule of when you want it to get tested depending on what the levels are. But as far as treating that lead by what we call chelation, which means you give medication, calcium EDTA, Suxamar, you can't do that till the level hits 40. Okay, the side effects of the medications are such that we don't want to take a chance on a kid who's under 40, and the FDA hasn't approved it for a level less than 40. So unless you hit 40, we're not treating you.
Got it.
Okay, so there are a lot of controversies with that, but the point is still that we can't treat you unless you get to 40. So the levels being 1, 2, 3, 5, 10, 15 is still the same. We want to address every single child who has a potential to be lead poisoned in the same way of providing education. ISLES does a great job of making sure that the homes are cleaned up and we can get some abatement done. We've come from a point where we had no abatement resources in the state to now where in a town like Newark, they have permanent housing available for families that are affected by lead poisoning in the home. So we're doing a lot. It's funny for me to kind of advocate on what the DOH is doing, but yeah, we are doing a lot. And the only problem I found was that over the last 5-10 years, we were getting complacent. We were getting to the point where we said, we're doing a great job, let's just sit back, and that shouldn't have happened, and it did happen. But fortunately, we got grants from the, from you guys for the post-Sandy work, and I've been involved with education throughout the state, both for providers, community organizations, school districts, and we've been going around and talking to everybody saying, you need to make sure that this is on the forefront, because as everybody knows, unless you're thinking of something, you're not going to recognize it. So we want to make sure that everybody's aware that this is a problem that is still there in New Jersey, and if we're not watching it, we are seeing numbers creep up again in communities where, somebody left off and didn't do their due diligence on screening these kids. So we have laws. Every child in the state of New Jersey has to have a lead level at age 1 and age 2. And we, post-Sandy, DOH put out regulations that if you live in one of those 9 counties that Sandy affected, you better make sure there's another lead level done. Doesn't matter how many lead levels were done before, but we want one now for this year. If you're under the age of 6. So, we're out there, we're trying to work hard, we just want to make sure education gets out there so the parents are aware of what they need to be looking for. Make sure that that child had a lead level done. Make sure the schools are aware that when that form comes in, there's a lead level on that screen. In my practice, we won't fill up that form till you get the blood test done and we have the results back. That's an incentive for us to make sure that the parents get the blood test done, and it's making sure that the parents are aware that it's very important that they need to know what the results are before they go back into school. And I think that's very important to educate both the parents, community, schools, all providers that this is something that we need to be looking for very importantly. So like I said, the most important thing is education, education, education. Once it's 40, it's too late. Those are the kids that we're finding having a big problem. It's a social stigma, and agreed, but the point is that you've created it by not taking care of that child when he had a level of a 5 or 10 and making sure that it wasn't getting any higher.
Thank you, doctors, for your testimony. So my question is, you say educate, 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 and you're collecting the data from boards of education or from the schools. Why isn't it automatic that education returns to the Department of Education or returns to the schools so the educators know you have a problem here with the kids?
Well, the Department of Health has the data, and the school districts that do use those universal forms do get the data. I don't know what they do with the data, but they do get the data.
And I'm sorry if I missed this, I had to step out for a second. But with respect to lowering the potential for lead contamination in some of these older homes and recognizing that it could be generationally before we can actually switch out pipes and everything else, as a lower cost, easy fix to that, are there filters that can be utilized in some of these homes to reduce that risk?
I think he wants to answer that.
All right. There are filters. Well, they're not filters, but there are treatment devices. The problem with treatment devices that are used within the home is that they have to be monitored routinely. They have to have their resins replaced routinely, because otherwise the materials actually build up to the filter where it supersaturates, and it dumps a much higher concentration of that contaminant than what was in the original water. So yeah, point of entry treatment, as they're called, or point of use treatment that you would have on a tap, they're there, that you could do it, but it's fraught with potential difficulties. You'd be far better off, frankly, buying jugs of water for potable purposes and then using your regular water supply for everything else. But even better yet is for the water utility to be properly adding anti-corrosion materials to their water supply so that you don't have that problem. Now, obviously, if you're on a domestic well, two things. One is you're on your own in terms, it's your well, it's your plumbing, it's your home. Therefore, you're going to have to deal with it. So then the question is, well, what's better from your family's perspective? Replace the lead lines, take out the lead solder, or have a treatment device. The advantage to taking out all of the lead from your system is that it's permanent. Once you're done, you're done.
Recognize that, but from a pragmatic perspective, because you provided testimony, and I think people agree, it could be decades before you're replacing all of these entire systems. So, in educating people and going out there and trying to reduce whatever is currently taking place, looking at other options that exist, it would seem to be a more plausible option if people are doing what they're supposed to be doing, whether or not it's a landlord, whether or not it's a person who owns the home themselves or a resident, and knowing, okay, every 6 months I've got to change this filter, or once a year I've got to change this filter, as you do with your carbon monoxide, as you do with a whole host of other things in your homes, and make it part and parcel of an educational campaign.
You answered that. Mr. Peterson, do you have a question?
A question. So, look, I agree with you that eliminating the source is always the best way, but we have to be practical as well. I was reading a Texas A&M study and on corrosion, especially with copper and lead piping. And they recommend that one easy and inexpensive way to reduce the possibility of lead in the water is to run the water and clear the lines, and then the water that's coming in wouldn't have the lead in it, because the lead is sitting in the water as a concentration, because when it's corroding, it sits when it corrodes. It's not when it's running through the pipes itself. So is Texas A&M idea of running the water, clearing the pipes, a good one, in your opinion?
It's fairly routine for people to be advised to run their water if they're in a home that has lead pipes, anything like that. And you can do that even if there is treatment on the supply. Difficulty there, try doing that with a multifamily apartment complex, something of that nature, which of course you have a lot of in our urban areas. There's a lot of water sitting in those pipes, and so one person running their faucet for a little while is not going to clear that water through. So for a single-family home, yes, feasible. Wastes a fair amount of water, but it's absolutely feasible, and from a health perspective might be the thing to do.
One question I had was this question of, was when they do the testing, talking to the DEP, they are doing a sort of statistical analysis of what's going on in an area. Now, we've just heard that, you know, housing stock, if I've built on this block and my builder or might have used copper pipe with lead solder, or somebody else might have used lead in another neighborhood. If you do spot testing, get a statistical overlay, your house, your particular house, may have an issue that won't show up in a statistical survey. Isn't that, I mean, that's got to be, so I'm concerned about that person who is not aware of the kind of pipe that they have in their particular home. How do we make sure that that person, maybe you'll catch them by testing, yes, maybe not, but what do we do? How should we change our testing regime, our surveillance regime, to make sure that, because all of these things are devastating. You've got 10 people. That's, you know, if it's $32,000 a year times 10, that's a lot of money. And worse than that is it's a life that might not very well reach its full potential, because they might not get the $32,000. But you've done something systemically that's damaged that person. So, what do you recommend that we do about those idiosyncrasies that are not going to be picked up in a testing program that necessarily does, you know, sort of statistical analysis that says generally things are such? But for myself or yourself, you now have a problem that's not picked up in the testing, so the action level isn't hit, right. And now you're sitting there with an issue. How do you suggest we deal with that?
There are a couple of issues in there. One is even getting access to people's homes to do the testing by the water company so that they can be included within the statistical analysis. Because some people refuse to allow access. So you have that issue, and then you have the issue that you're raising. So somebody leaves a note there that says, we came to test water and you didn't let us in, and so they know at least what they're doing if they deny access. Yes. So the Passaic Valley Water Commission, for instance, has a program where they will do lead testing in somebody's home. All you have to do is get in contact with them, and they do it. So you can do those kinds of programs where you essentially provide it as a free service. The notion of having an educational flyer or whatever that goes out to all of the customers within a utility service area. The notion of, in rental areas, having the water tested prior to a new tenant coming in.
That needs to happen.
You know,
sure.
those, yeah. So it's not an easy process no matter what. There is, without a doubt, a certain level of personal responsibility that comes into this. And the problem, of course, is that many people have no idea that they have that personal responsibility. Water is supposed to be safe. Well, I never use the word safe when I'm talking about water. I use the term, it meets standards.
Or acceptable, maybe, I don't know. Dr. Rod, you had something to add?
Yeah, I think kind of covered it. Basically, the point is to try to get the utilities, because a lot of New Jersey, is still covered by well water, but the point with the well water is then at the point of a CO of a sale, basically to include that. Right now, we do the radon. So the mortgage company says that, if you're going to make a sale, I want to see the radon impact before I give you a mortgage. Same thing they can say, we want a lead impact before we give you the mortgage. And, that would be a way to get the insurance companies to pay for it, or get the mortgage companies to pay for it.
I rented a house recently, and that was an issue, and it was a private well, and it was very vexing, I can tell you. And it's one of the other reasons I'm very interested in this issue, because I think rules need to be tightened up around these private wells, quite frankly, particularly on these transfers and rentals and the like. I want to move on if I can. Thank you, doctors. I appreciate it. We have Jeff Tittle from the Sierra Club, Doug Plaka from Genesso, Jim Walsh, Food and Water Watch. There's somebody else.
Thank you. Jeff Tittle, New Jersey Sierra Club, and I'll try not to repeat anything that was said by any of the previous speakers, because some of that stuff was some of the issues I wanted to touch base on. I want to start off and say that, we worked many years ago with Assemblyman Geist at the time to get the private well testing bill passed, and it was a way of trying to get into these homes where we're concerned. And by the way, the state of New Jersey has not released the data from the Private Well Testing Act for the last 5 years, which is something the Health Committee should look at, because quite frankly, a third of those wells showed levels of contamination when we were actually getting the data. The reason I wanted to start off with that, because I think that's the kind of program that needs to be expanded into multifamilies and homes, because the biggest problem we have in the state when it comes to lead in our drinking water are these pipes. I watched across the street here when they dug up State Street about 10 years ago, and they brought up pipes that were from the Victorian era. They were basically wrought iron pipes that were drilled through logs that were cedar to help protect those pipes from, buses or whatever, back then probably horse and buggy. Point is, we have a very old and aging infrastructure in New Jersey, in all of our urban areas in particular, and in many of our older towns. And those systems not only have lead in them, there's other chemicals, they also allow for infiltration of water into them because they're porous in places. And it's a major problem. It's at least an $8 billion problem to fix. Quarter of our water in urban areas leaks out of those pipes, and we lose that. And so one of the ways we could help pay for fixing some of these issues is maybe recapturing that water and reselling it. But the point I want to get back specifically to lead. Lead is a neurotoxin. We know how horrible it is. Yet the state of New Jersey, the action level in drinking water is 15 parts per billion, even though there's no safe standards. So when you're talking about children, especially children who use a lot more water per pound than an adult, we should not have any lead in our drinking water, and it is a major problem. And the problem is that in these older towns and communities, we have lead pipes, we have lead solder, we have a system that's broken, and we're not doing a proper enough job to test in those homes to make sure that that water is safe. We have a great program in source water, what's in the reservoirs, what's coming out of the filtration plant, but not at the end. And that is a real problem, and that has to get addressed, and that's why I think expanding testing would be helpful, but that's not the only thing. One of the problems we also have is chloride. Chloride is used because we use a lot of chlorine in the state, and chloride helps leach lead out of pipes. That is a chemical fact. And we use orthophosphorus and other things to try to knock down, the pH so that there's less leaching. But there's also health impacts from that as well. So we have a system that's broken, and the best way, Dean Knoll, who was the chief engineer of the North Jersey District Water Supply Commission, who I knew very well growing up since my family was up in Ringwood, said the most cost-effective and best way to have safe drinking water is to make sure it's pure in the first place. And we really need to spend time fixing this aging infrastructure system. But we also have other serious problems, and I know it's getting late, so I just want to touch on them quickly. The New Jersey Drinking Water Quality Institute didn't meet for more than 5 years. They haven't set a standard, and DEP hasn't adopted a new standard under this administration. We have PFOA in Wells in South Jersey and Gloucester County. We have TCE and PCE in Wells in Morristown, and yet we haven't adopted a standard. Big problem we see also is that many of these problems could be cured, especially in community systems with wells, if we went to carbon filters. It doesn't clean up the site, but at least it'll make people healthier in the meantime. And that's a real problem that we see here. We also have a regulation in place that we don't have rules stricter than the feds. Well, our drinking water should be at 1,000,000 to 1 standard. A big problem that we're facing in the state, and that's why I mentioned chloride before, is THM, trihalomethane. Trihalomethane is a chemical die-off that happens when you use chlorine to treat waterways when there's a lot of bacteria in it. And what happens is the chlorine kills it, and this is a byproduct. And in many parts of New Jersey, it is up in and around the EPA health standard of 80, including Lambertville, where I live. Some water companies, in order to try to knock down the THM levels, throw ammonia in there, which causes another series of health problems. And we have that problem in Bergen County, by the way, and with E-Town water in places too. So we have a real serious water problem in the state and the health impacts because THM is carcinogenic and causes birth defects. We can move away from chlorine, but we still will always use a certain amount in the pipes because of infill of water in old pipes. Ozone treatment and reverse osmosis is very expensive. So what we really need to look at is the overall water systems in New Jersey when it comes to health. We only have set standards on 100 chemicals. There's 3,000 out there. So we have a broken problem in the state. Enforcement for water inspections are down almost 60% in the last 6 years. So we don't even know what's happening in some of these places.
Are they down?
I would say it's the philosophy of the Department of Environmental Protection under this administration. Also loss of staff. And we have wells. There are 300 contaminated sites in New Jersey that are directly impacting potable water supply wells, and these are Class C and D sites. These are very complex and dirty sites. Do you realize that the well field for the city of Camden is in a place today it would be illegal to drill a well? It's called a categorical exemption area. But because that well's been existing, it's grandfathered, and that's where Pennsauken gets its water, and where Camden. Same thing is true with Atlantic City. And yet, instead of fixing those problems and cleaning up those, or moving those wells, we may be privatizing those water systems, which will be a whole other set of problems I'm sure Jim will talk about. But the point I was trying to make is we have serious problems in the state when it comes to toxins getting into our water systems and not actually making sure that the sources themselves are safe in many parts of New Jersey. When we look at Camden, and I want to use that as an example, when the Tri-County pipeline was built, it was supposed to go to replace Camden's well field, but instead we're shipping that water into the suburbs for growth and not putting it into the cities where it needs. We have major problems when it comes to infrastructure and water quality, and they're interrelated in the state. And it's been a long time since any body in this government has really spent time in addressing it, and it's long overdue, so I thank this committee for doing it. And I just want to end with, the old saying, is this glass half empty or half full? Test the water before you drink it, because you won't know otherwise. Thank you.
Questions till the end. And Mr. Henry, I think, why don't you make your way up, and then we'll move down the line to Mr. Walsh to get started as Mr. Henry's moving his way
Great.
to a seat.
Thank you very much, Chairman, for...
Stay over here in the middle so we can see. Move over here so we can see. Thank you. Go ahead. Mm-hmm.
Thank you, Chairman, members of the committee, for taking time to consider this really important issue. I'd like to lay out specifically some of the things that we saw happen in Flint. And Food and Water Watch, so folks know, we have 19 offices across the country. One of those offices is in Michigan, and our staff is working in Michigan and has been working with residents and community organizations in Flint around this issue. What happened in Flint goes back to a state takeover that happened in Flint where emergency managers were put in place to make decisions for the community. And the decisions that were made in that state takeover essentially were to override a municipal decision where the municipality...
Mike. Let's...
Yes, sir.
Flint is a huge issue, and I actually, when that broke, I actually sort of looked to see... they actually meet criteria for genocide. If you look at what the UN says, it was striking when you look at the things that happened. But The reason I'm interrupting is this.
Yes, sir.
Flint should, if it's referenced, should we reference back to? Do we have
I
concerns
plan to
here?
do
So
that, sir.
Let's say.
And it's actually really relevant, and I'll later in my marks, I'll talk about Atlantic City and the things that are happening there right now as it relates to an emergency manager as well as the pending state takeover. So it's very relevant. Where you had somebody who was an outsider essentially making decisions about the water system, the residents or the council in Flint voted to hook up to a new water system that the county was putting in, and that was then overridden by the emergency manager who hooked them up to the Flint River. And the Flint River was more acidic and had very high levels of corrosive chlorine in it, or chloride in it. And that caused iron to leach out of the system. And this then caused more, the iron interacts with chlorine, which then inhibits the ability of the chlorine to treat the water, which then had more, the need for more chlorine to be added. There's a UVA study that actually looks at and draws a link between the chloride to sulfite ratio as being one of the major determining factors in whether or not you're going to have lead leaching out of pipes. And so in this process, we actually wound up, they wound up switching to this more acidic water. They stopped using the phosphates in the water that they were using and started actually adding an iron chloride. So that switch actually dramatically increased the amounts of chlorides in the water, causing additional leaching and just a feedback loop that wound up having more and more leaching go forward. And so this is, really the result of looking to run a water system like a business. They remove local control in the decision making, and there's actually an active cover-up going on, or investigation going on right now, and about the inadequate testing and other things that were going on. When we look at the problem moving forward and how this impacts New Jersey, we are going to have to spend a significant amount of money to actually fix this problem. There's no avoiding that. What I want to talk about is how do we pay for it? And these are very important decisions that we have to make. If we don't put the resources publicly into actually paying for the fixing of the ailing infrastructure, we're going to continue to have problems like this in New Jersey and elsewhere across the country. And the federal government does provide some money in financing that we have available through the state revolving fund here in the state. But that financing is leaving tremendous amounts of money on the table every year. There's inadequate money to actually deal with funding for pipes and those sorts of infrastructure. A lot of the funding actually goes for water treatment facilities and things like that. And so this really, I think, asks the question, because if we don't provide the public money, the only place that municipalities are going to have to turn is either dramatically increasing rates at the local level or looking at privatization. And when they look at privatization, they actually wind up paying a lot more in the long run, but the upfront costs to the municipality appear to be lower. And the reason, there's a number of things that contribute to higher cost in privatization. And we just did a study comparing public and private utilities here in New Jersey for providing water, and found that private water companies actually charge about 2/3 as much for water as public utilities do. And that money is money that's essentially being skimmed off the top that could otherwise be used to provide further investment.
They charge 2/3 more.
That's correct, sir.
I thought you said as much.
Oh, sorry, 2/3 more.
Okay.
Yes. 2/3 more by private companies charge 2/3 more. Sorry, thank you. They charge 2/3 more than public utilities, which then, essentially is skimming off the top. The city of New Brunswick just ended a management contract with a private water company that was costing the city about $850,000 a year. These are resources that could be invested back in the water system rather than essentially going to corporate, CEO salaries and things like that. When we look at Atlantic City and what's happening there right now with the takeover, a lot of the discussion right now is about what to do with the water system there. There's been ongoing discussions in Atlantic City for well over a year about the sale of the water system. Immediately after the legislature passed a bill taking away the ability of communities to vote on water privatization contracts, private water companies started showing up at Atlantic City Council meetings and working to push privatization there. We worked with residents in Atlantic City and community organizations to educate them about these problems with privatization. Now you have the mayor and council opposing this, but what's happened is you actually have now a bill being proposed to bail out Atlantic City, and a separate bill that will be proposed to deal with the takeover of the water system. And that takeover bill will essentially force Atlantic City to do what the mayor and council don't want to do and privatize the system. And this is running into this dynamic where we want to, run these water systems and look at them as cash cows and look at them as revenue sources. And the reality is they're not revenue sources. What they are is something that we have in place to provide a basic human right to people. And when you start thinking about them like business opportunities, you make those decisions like we're done in Flint to not hook up to the county system, but to hook up to the Flint River, or to not add phosphates because the price was going up and add other additives to those systems. And so we need to look at these as important human rights and working to ensure that those human rights are maintained. And so when you guys here in this committee are going to be probably voting on an Atlantic City bailout bill within the next month. And when you vote on that, there'll be another bill attached to it. It'll move as two bills as being proposed right now. One that will actually provide resources through a pilot program to Atlantic City, and another that will propose the takeover. And my biggest concern that happens is this takeover bill gets passed that forces a water privatization upon the city. But then you also will have this other legislation that purports to provide aid to the municipality to support them. And that bill has been vetoed by the governor. It will probably be vetoed again. But then he signs the takeover bill, which will mean even more draconian measures will be necessary in Atlantic City to actually stabilize the economy there. So I want to thank you all for your attention to this matter and thinking about this. I think that there's a lot of investment that needs to be done and a lot of consideration about how we support struggling municipalities and provide resources to address water infrastructure needs in the state. Thank you.
Michael, and
Yes, sir.
It's amazing what happens when you, but let me just say, you mentioned how to pay for it.
Yes.
Now, you mentioned what not to do.
Yes, sir. Okay.
And that was not to privatize wells.
That's right.
Because you begin to pay a lot more, you say, for costs related to the sort of private aspect, corporate costs and other things, and that decisions might be modified in respect to these needs now to provide profit, rather than than a profit that's just based to maintain the utility plus some build-in for maintaining infrastructure and the like. Is there quickly so if we don't privatize, what do we do to raise the money for it? Now, I heard we stopped losing water. Okay, that's an idea. Mm-hmm. Anything else to add to that, and how do we pay for it other than raising rates? Any other
Sure.
thoughts?
I think there's a number of things that the state government could do to help to raise resources for this. One is potentially looking at fees on bottled beverages. Other states charge fees as ways to actually induce recycling. We could actually charge a fee on bottled beverage sales, particularly even bottled water sales, and there's that could actually be used to fund public drinking water infrastructure. And if you look at this from a standpoint of that bottled water sales are actually directly undermining our public drinking water system, because we treat all of our water to a drinkable standard, right? Or, what we consider drinkable, but then we actually purchase bottled water and then drink that and use the entire rest of the house for bathing and all these other things that aren't necessarily needing to be at a drinkable standard for watering our lawns and things like that. So you could potentially put a fee on those beverages to help to increase money. There's the Better Choices Coalition, which we're a part of, is proposing a number of measures that could be used to raise revenue in the state through looking at fair taxes and fair tax system in the state of New Jersey and raising taxes. I think that also the state could look at creating looking at the current environmental infrastructure trust, and there's money left on the table there that isn't getting to municipalities. So potentially the state could have some power to come in and change, to do things to incentivize municipalities to actually get money from that environmental trust, or potentially if the federal requirements for that trust are too challenging, which I've had many water purveyors tell me that the requirements for applications are challenging, the state could actually create a side pot of money, and that side pot of money could be used specifically to repair pipes and upgrade and maintain pipes.
Thank you.
So I think that would be important.
Mr. Plaka.
Good afternoon, I guess now, Mr. Chairman,
Yes.
and committee members. Thank you for this
We're used to it over here.
Thank you for this opportunity to address you this morning. You have copies of my comments, so in the interest of brevity, I will tailor those comments for you this morning. I won't be citing statistical information. I think the previous speakers have already done. I take that back. I'll cite one statistic. We represent over 5,000 nurses and hospital technicians throughout Pennsylvania and New Jersey. We also represent, and included in that 5,000, we represent the nurses at the City of Newark's Department of Health and Community Wellness. And I've asked to join me today Therese Calhoun, who is Genesso's community organizer, but she's also the recent chair of Newark's annual Healthy Homes-led awareness walk. And I'll ask her just to say a few comments once I'm finished. Our membership partners with community organizations throughout the City of Newark to bring awareness to this dangerous reality, providing information about ways to reduce children's exposure and risk factors, encouraging parents to understand the history of the buildings in which they live and raise their families, particularly if they're considering any home improvements or renovation. It's an important step in this process. This helps parents take the necessary precautions to protect their families before undertaking any project that might put their children at risk. Educating the public about best practices to prevent lead exposure also includes simple reminders of regular hand washing, cleaning children's toys frequently, and keeping children away from bare soil when playing outdoors. It also involves providing parents the information about how to store food and liquid in lead-free containers, as well as how to minimize risks when preparing baby formula for young children. Our membership also participates in Newark's annual Healthy Homes-led awareness walk, which seeks to raise awareness throughout the city and gain the attention of families who may be at risk of lead exposure in their homes. And such efforts have touched the lives of many families throughout the city. So if there are other ways for this body to explore as to how to educate the public, by all means, we are certainly willing to stand by and help in any way possible. Newark just being one stop, that's where we have our where we represent our members. So I'd just like to ask Therese to just talk about what it is in her experience as the chair of the Healthy Homes-led awareness walk.
Good afternoon, everyone. Thank you for allowing me to address you on this very important issue.
Push your mic on, ma'am.
My throat is a little scratchy. My name is Therese Calhoun, community organizer at Genesso. One of my roles and responsibilities as a Genesso employee is to build relationships and collaborate with other stakeholders to address healthcare issues relevant to our members and the patient populations that they serve. In 2014, I was assigned to the City of Newark. Just like Mr. Plucker said, Genesso represents the City of Newark public health nurses, including nurses that are lead educators. Early in this assignment, I connected with various organizations that over the years have been educating the community of the dangers of lead and advocating for the families of children that were affected by lead. At one of the meetings, the idea of a lead awareness was discussed, and I was asked to chair. I accepted. On September 14, 2014, we organized the first annual lead awareness walk. The lead awareness walk consisted of children from local daycares, speeches from Genesso leadership, elected officials, and other community leaders. Vendors provided information and resources that were sent home with the children as it pertains to lead hazards and precautionary methods. Children entertainment consisted of face painting and a cartoonist, because we had to entertain, of course, the kids. There was light refreshments for everyone. 2 weeks later, the group met, and we were told that the parents were taken back by what they were reading. They thought lead was dead. They expressed appreciation for the information and began acting on what they learned. It is fair to say that the walk was a success. This is just one of the many approaches to bringing awareness of the dangers of lead and how to avoid exposure. What I learned thus far: lead is not dead. Children are still being poisoned with lead. Education, education, education. Testing mandated for children entering schools, child care centers is a must. There are so many other things I want to talk about, but the other speakers did address it, so I want to thank you.
Thank you for the information provided. Mr. Henry, please. Close us out.
Yes, thank you very much, Chairman and committee, and thanks for allowing me to testify. Basically, I represent the New Jersey Association of County and City Health Officials, so we're approximately 92 health departments that represent the 8 million people in the state. So basically, I'm not going to repeat anything that my colleagues had basically said, but basically last night when I was looking for this, this is the whole annual report from 2014 from the State Health Department on childhood lead poisoning in New Jersey. So, I mean, that has all the data, very easy for me to download from the state website, actually, to discuss some of these issues. And briefly, I'll just say that, you know, obviously lead in the water is a concern to us, and we're involved in basically the whole area of lead prevention and lead poisoning. Like my colleague from Newark was basically saying, I mean, education is an important piece. Intervention is an important piece also. The issue that our action level or actionable level is at 10 deciliters, 10 micrograms per deciliter is where we start our environmental interventions. So we do get the lead data from the physicians and the public health agencies and clinics indicating elevated lead levels. When we get those levels, we go right in and work on those issues right away, either through doing lead analysis, finding out if their water supply is good. We do the whole area. It can be very challenging because some of the cases of trying to abate lead hazards can take up to a year or more to do, depending on how cooperative the landlords are, how you want to take landlords to court, and how long that takes. I mean, it can be extraordinarily challenging. Also in the audience is one of my colleagues from the Monmouth County Health Department, and they work as well as Newark and other municipalities and counties on healthy homes, trying to educate. And I think also the Monmouth County also has the Hurricane Sandy lead abatement program as well, where they're actually trying to increase the level of testing that goes on in the state. You know, and I'll echo my colleague from Newark, basically saying that there's more testing that needs to be done in children. If you want to find out where the addition of the problems are, I mean, the more testing, the better. And when we get the data, we just go to work in those areas. Also, the state has something called lead tracks. So if the elevated lead levels are found, they go into a system called lead tracks that we enter data in, and we watch that data as well. Obviously, it's protected by HIPAA, so a lot of times people won't get the data from this. But the data really ends up in here in the annual report, and we work on it from that standpoint. Also, again, I wanted to also talk about that we work at that 10 level. And actually, in these reports, you can see the number of kids that are between 5 and 9. And going to that level, if the state or if the committee is looking to go to that level, to a lower level or actionable level, we as local public health are facing the same challenges as the municipalities and counties. If you want us to address those 3,000 to 5,000 more children in that level, we need some additional funding to actually do that, just from the equipment standpoint and the personnel standpoint. I can tell you personally, since I represent 22 local health departments in my health department at the Regional Health Commission in Monmouth County, we lend our meters out in a shared services type of way. So there are ways to economically do this, you know. And
what meter is this? Is this
It's a lead analyzer checking for homes for lead dust, lead paint, things along those lines.
I see. Mm-hmm.
But you know, but those are areas that we can do. So the lead pumping in the pipes has been talked about. Lead abatements are ongoing, and there are a variety of levels of lead abatements throughout the state and throughout the cities. And basically, somebody mentioned about prenatal education. You know, there's a lot of education going on. I know I also am on the board of the Central Jersey Family Health Consortium as well. They do a lot of data and a lot of information in regards to prenatal services and prenatal work and prenatal education. I think what happens is to invite and start dialoguing with those consortium members to find out what additional efforts can be made to do more education at the prenatal level, and more testing at the pre-K level, testing at the kindergarten level, and basically we see the lead laboratory results. We see the private well testing data as well. I mean, I can tell you, I get maybe out of my 22 towns, I get maybe 1 or 2 of those private well testing results coming through my office at least once or twice a week. And then we pass that on. Any exceedance, which includes lead, you know, we pass that on to try and get abated. But basically, I'm thankful that you have allowed us to testify today, and our association is more than willing to work with all of our colleagues to make it better for our children in the state of New Jersey. And basically,
Thank you. Thanks.
Thank you very much.
Now, anybody else out there on water quality that perhaps is new and didn't think to put a slip in?
Chairman, I had
Mr.
one
Walsh?
other funding thought for you. Just last year, the state of New Jersey awarded American Water $164 million to move their headquarters from Voorhees to Camden. And programs that are going to allow those sorts of public resources to be doled out for a very profitable water company that is charging exceptionally high rates is certainly misappropriated funds. And any money in this year's budget that's in that ADA program that could be allocated otherwise should be cut and put into social programs, increasing our water infrastructure and things like that. Thank you.
Getting your licks in there, I tell you.
I got one quick thing. Just that there's money in this year's budget that's being diverted from the 1981 Water Quality Bond Act that was passed. And every year for the last 20 years, about $8 million gets taken out and taken to DEP for salaries. And that's money that could have actually gone out to help towns, and I think we tend to forget that.
But
That's a little bit. It's a little bit, but my point is that, and the fact that the New Jersey Water Supply Master Plan, which is supposed to be done every 5 years, was last done in 1995, is another shame that we have when it comes to
Shutting the lights out on us.
So anyway,
Mr. Eustace, Mr. Peterson.
Thank you all for your testimony. One of the things I think is important is to remind everybody that the CDC recommendation is 5. New Jersey's operating on 10. I think it's irresponsible for us to move forward and leave it at 10, and hopefully we'll do something about that. And if we're talking about water quality, you brought up trichloromethane, and most recently perfluorooctanoic acid, PFOA, is found in several places in New Jersey. New Jersey did fund a study in Ridgewood, New Jersey, up by us, I think $1.2 million, I'm sorry. And this has been going on for a couple of years, and I think we need to see the results of the study and add these toxins to our list. And hopefully we'll be able to, as we talk about water quality, we'll be able to talk about newer, not really newer, this was a Teflon additive, but as these things crop up, we should add them and move forward and make sure that these aren't affecting our children. And I believe this is a crisis. If you're talking about 3,000 children in the state of New Jersey, if that were our children, I think we would stand up and run for the doors and make sure something happened. That's it.
Well, you're right, and when you have parts of the water infrastructure that just have been prevented from doing their job, it's a problem because we can't get these new standards put in place when they're needed. Mr. Peterson.
I have a question for Mr. Tittle. You said that the Camden City well is in a location where the water being drawn out of it is toxic?
it's in what's called a categorical exemption area in the DEP, which means that you cannot drill a new well there. but it's grandfathered in even though it's in a contaminated site, absolutely.
Is the water contaminated?
Well, they have filters on it and things like that. The question is, what gets through? I mean, there's been a class action suit by citizens in Camden over the years against the water authority there because of the contamination. And this is the second time they've actually moved their well. So they have a serious problem there. And because we don't test, remember, we only test for and have standards set for about 100 chemicals. Other chemicals that may be in the water, we do not have standards for. Therefore, if they're there, like TCE and PCE, unless they're a certain level, they go through.
And that's the same with Atlantic City?
Yes. Atlantic City's well field is also in a contaminated area. Not as contaminated, but it's near a toxic site, so they have problems there too. We have a lot of wells in New Jersey. What people don't realize that one of the reasons the Highlands has become so important, as you well know, for water supply, especially Spruce Run around Valley Reservoir, we've closed more than 1,000 potable water supply wells in New Jersey in the last 25 years because of contamination. We even had one, this is going to sound really hard to believe, up until a few years ago where the Garden State Parkway and Route 22 is, we actually had a potable well there from E-Town. So we have a serious problem in New Jersey. We may be the first state east of the Rockies to run out of water. Ours is because of overdevelopment and because of contamination. I mean, we really have a serious problem long-term in New Jersey with contamination in our groundwater and into our wells.
And both the Camden and the Atlantic City systems are currently run by a government entity?
You know, we believe in whether it's a public system or a private system, you need the state to be a watchdog and to do testing. We tend to think that there are problems with public systems. We've had people in East Orange and other places go to jail for falsifying reports. If there's political pressure to look the other way, it doesn't matter if it's public or private. We've also seen in Indiana and other places private systems where they've been indicted. We believe a public system is more accountable because you can go to your council member and yell at them if there's a problem, or you can go to your government, you know, your town hall. So we think public systems are a hell of a lot more accountable. We think North Jersey Water Supply Commission is more accountable to the people than, let's say, you know, United Water. Well, United Water, which is headquartered in France. You know, it's a little bit easier to go to your council meeting and yell at them versus trying to go to France.
They have sovereign immunity, private companies?
Well, let's just put it this way. There are a lot of problems with being able to get accountability from private companies, especially when they're headquartered in, you know, overseas or out of state.
Well, in Lambertville, where you live, correct?
It's United Water, yes.
Yep. So, and that was sold several years ago, and part of that was because the government water company was undercapitalized and couldn't fix the dam that was going to breach and flood the town.
Yep.
So government-run water companies are no panacea of goodness either. They have problems.
Though I will say that water has high levels of THM, and when I have a chance, I'm going to go yell at Mayor Dave about it. The other thing is that the money to fix the dam actually came from public money.
So, well, they probably, what was the source of the money?
They got it out of the state infrastructure trust.
But there was other infrastructure problems other than the dam that was with that whole system that had to be.
Yeah, I was just, because I almost had to evacuate, so I do know that dam quite well.
Yeah, I was.
And now they want to put a pipeline through it, but that's another story.
Well, all right. You know what, for sake of time, I'm going to end it there.
Okay, well, I thank the committee for their patience in getting through this. We have had some long meetings, as you know. I actually thought we might be able to do this in the afternoon, but I guess it's good that we've been able to run straight through to it and at least a late lunch, if nothing better. I appreciate the indulgence of all of you to stay here and listen to this testimony, and look forward to your efforts and our collective efforts to address what is a serious concern for the state of New Jersey. Thank you. We're adjourned.